Now declare open the public hearing for the Standing Committee of Social Policy and Legal Affairs inquiry into the relationship between domestic and family and sexual violence and suicide. I'd like to acknowledge the traditional custodians of the country on which we meet today and pay my respects to their ancestors and elders, past, present and emerging. I extend this respect to all Aboriginal and Torres Strait Islander peoples and their cultural and spiritual connections to Australia's lands and waters. This hearing will be broadcast and the transcript of proceedings will be published on the Parliament's website. For those in person or listening online, please be advised that this hearing may contain evidence that could cause distress. If anything you hear today upsets you or causes distress, please reach out to 1800 RESPECT, Lifeline, 13 Yarn, Kids Helpline or other support services. There is also the Parliamentary Workplace Support Service and Employee Assistance Program for broadcasting Hansard, the Committee Secretariat, the Committee and its members' staff. I now welcome Associate Professor Melanie Turner to give evidence. For the Hansard record, would you please state your full name and the capacity in which you appear before the committee?
Thank you. My name is Associate Professor Melanie Turner. I'm the Chief Psychiatrist of South Australia and I've been asked to attend today representing part of SA Health with regards to domestic, family and sexual violence and our responses and data and information regarding that.
Thank you, Dr Turner. Although you are not required to give evidence under oath, this hearing is a legal proceeding of the Parliament and it has the same standing as proceedings of the House. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. We are a blended meeting today. We are partly online and partly in person, so I'll just do a quick whip around so you know who's here. I'm Louise Miller-Frost, the member for Boothby. I think you're my local constituent.
Alex Hawke, the Deputy Chair from New South Wales.
Thank you.
Craig Callaghan, member for Sturt in South Australia.
And we have online Mr Gregg. On mute. Yep. You're on mute, Matt.
Sorry, Matthew Gregg, member for Deakin.
Mr Ng.
It's Gabriel Ng, the member for Menzies and Melbourne East.
And Ms Whitty.
And Sarah Whitty, member for Melbourne.
Thank you. Dr Turner, do you have a brief opening statement before we proceed to discussion?
I do. I'm not sure how brief. I tried to cut it down to 5 minutes, so I hope that's an okay time frame for everybody.
Absolutely.
Right. Thank you. So thank you for inviting us to come and speak as a part of sort of the SA Health approach. I thought that I would help cover our suicide registry, which we run in the Office of the Chief Psychiatrist, as well as information around our health response and information from the Women's and Children's Health Network, which in South Australia does a lot of the response for women and children with regards to domestic and family violence. We, as the Office of the Chief Psychiatrist, have been running the South Australian Suicide Register since 2020, and we're one of the first states to have suicide prevention legislation. Sorry, I'm getting over laryngitis. So this particular registry is a part of what I look after in my role. I have 2 coders and they undertake a comprehensive review of all of the suicide information and deaths we receive from the coroner, and we capture more than 250 variables on average relating to the circumstances of death. For this committee's purposes, the key information we collect is around abuse and violence, including sexual abuse, domestic and family violence, Department for Child Protection involvement and other relevant stresses that are identified in our source material. The register records whether the deceased was identified as a victim survivor, perpetrator or had another form of involvement. We also are able to note whether legislative orders were identified in that source material and whether they were subject to relevant legislative provisions at the time of death. In South Australia, this relates to intervention orders, the Child Sex Offenders Registration Act and the Children and Young People Safety Act. In our register, we also record mental health service contact, including in the last 9 mental health service-related encounters before death, and where we can, this is enabled to be extended to both private as well as public mental health contacts. My team has collected specific data that I can present to this committee, and this information has been extracted for the purposes of the committee, so you won't find this published in other places in this detail. The data ranges from the 1st of January 2019 to the 10th of July, and we chose this 7-year period because it's the totality of the register, which we thought would be most helpful, but also gives more accurate data. We had 1,409 deaths by suicide in our state during that time. For this committee, it might be helpful to know that of these, 415 were identified as affected by abuse. Within those numbers, 241 were affected by domestic violence, 236 by sexual assault. 102 had Department for Child Protection involvement. This may be the small number of children that have died by suicide, but it also means the adults who will have had documented DCP involvement as a parent, guardian or foster carer of someone under DCP care. 63 had outlined another form of abuse recorded, which we list emotional abuse and other forms such as financial abuse in our register as well. And 152 described domestic violence only, and 146 had sexual assault only. And for sadly, 7 people, both of those were recorded within the 12 months prior to their death by suicide. What that means is that 29.5% of our people on the suicide register were affected by these kinds of abuse. For those recorded as a victim and perpetrator, we are able to record that as well, and that occurs in complex relationships. For those that filled both of those descriptions, 68% were men and 32% were women. If we're to look at those that just identify as perpetrators alone who die by suicide, that is 92% of them are male. Among people experiencing domestic violence, it's important to know that 90% had a mental health encounter in those last 12 months of their lives. 22% saw a GP and 27.5% were seen in an outpatient clinic, with a small percentage also having an inpatient admission. And another set of data shows that 38% had a legal contact in the 12 months before their death, and 21% had a contact less than 12 months, so within the last 6 months of being alive. The Women's and Children's Health Network in SA is responsible for providing care in our public health system. The acronym for our team is complicated, so it's the Health, Recovery and Trauma Safety Services Team, so HRATS. And they have looked into this for me and have described that there's ongoing research that shows the relationship of domestic, family and sexual violence is underdeveloped in Australia. A large study in the UK found 50% of people who attempted suicide experienced domestic violence at some point in their life. And in 2026, a study described perpetrators in domestic violence also may engage in suicide coercion indirectly, which they comment is seen frequently in people accessing their service, including texting, phone calls and threats that make people feel worthless, entrapped and isolated. And we know that entrapment is the biggest risk for people ending their lives by suicide. The team have developed their own pathway. They have the SA Health Family Safety Framework, which is called Ask, Assess and Respond, which they use as a screener for domestic and family violence occurring in female consumers. Unfortunately, the training isn't compulsory across all of our SA Health sites and is only for women aged 16 and over, so potentially missing a younger population, and of course men and women who don't necessarily present to the Women's and Children's Health Network. We also don't have an equivalent screening tool to capture sexual violence that occurs outside of domestic relationships, such as suicidality in the context of sexual violence, which we know is a significant concern with young women. There is the potential for victim survivors who are discharged sometimes to the person who's caused violence, particularly leaving emergency departments and crisis settings, with difficulties managing domestic, family and sexual violence at the acute point of discharge. The state-based DFSV specialist services continue to provide a comprehensive service for all of our patients and have tried to develop their own pathway for a gender-informed, violence-informed safety network. That's it.
Thank you very much, and thank you to you and your team for doing that research. That's really, really helpful information. We'll now come to the question and answer bit, so I'll start off. You mentioned, I think, early on, in terms of your codas having 250 variables,
Yes.
and I think you mentioned that you had some access to private mental health contacts as well as public. Can you talk about some of the sources of the data, so how those coders know to actually, where can they find out if somebody has had an experience of either family violence or sexual violence?
The information we have comes through a variety of pathways. So publicly we have the safety learning system, which for all of you will have a different name in each state. It's sort of the risk management system. In that SLS system, sometimes people will record a self-harm attempt and then describe a GP appointment, describe a psychology appointment. Discharge summaries may describe discharge for psychology follow-up. There may be inclusion of a discharge letter or a referral. The coroner's information, depending on where it is in the pathway of the coroner, getting that information may actually have a report, letter, information from private practitioners. Sometimes we'll actually receive information that's also been given by family members. They may have gone to appointments or follow-up. And depending on the pathway for that person, there may be significant information in their public notes when there's shared care between a private practitioner and the public hospital. Remembering that in South Australia we only have about 340 psychiatrists, so we're a reasonably small state, and a large number of our psychiatrists work in private and public. So occasionally what you'll have is sort of people that are referring and writing documents in their private and public practice as well.
And so is the health data really the gateway to this, or are you able to access data outside that? So, for instance, a family member might know about this, but if the person hasn't been to a psychiatrist or hasn't been at Children and Women's, is there any contact to get data outside that network?
We can. So if we, generally not just what goes into the registry, but if we investigate a particular case, so it's sitting within the framework of the Office of the Chief Psychiatrist in South Australia, we're a little different in our CP office compared to other states. So our information-related powers, I'm able to request from a number of sources, but with people's consent, I'm able to request things from sort of private practitioners. And in our coming mental health and wellbeing bill, depending on what gets passed, it may be that in actual fact that's able to be reached out to a range of other services such as Department of Corrections, Department of Child Protection. In general, what we find is that we aren't able to get all of the detailed information from private practitioners because of their own rights of confidentiality and their own level of concern around release of that information. But in general, speaking to family members and receiving information is how we get a lot of that, as well as written communication. I think as well that there are some challenging parts, obviously overlapping with what the coronial process is like and how that pathway is a challenge for all practitioners trying to share information into a suicide review. We strongly lean into the Towards Zero Suicide framework in South Australia, and that's the frame for which I use under the Suicide Prevention Act. And that talks about like a non-blame culture, a learning culture, a just culture, which, we try to encourage the sharing of information to look at these narratives and what occurs. But there's still a lot of worry from a range of practitioners around being in trouble for someone ending their life by suicide. And so we're constantly walking that kind of line between trying to find information but without, causing unnecessary fear in a clinician thinking we're blaming them for a death. So that's an ongoing kind of line we have. We have a really small team, so I have 2 coders and I have 1 epidemiologist. I think we do a great job with our little team. And we're very fortunate that when we started with a really large number of variables. And so I think when you start a really good data set with a large number of variables, what we have is consistency with what we've collected. And so we've been able to, and we have for those of you in Victoria, you'll know how special it is to have 1 medical record rather than so many. So in South Australia, we have 1 public health emergency electronic medical record called Sunrise that collects all the hospital data, and 1 mental health record in Metro called CBIS. And we have access to everything that's registered in that in my office. So that enables us to look a lot more. I think Victoria, you have, 12 different versions of medical records, I think. In Queensland, I think is about 7. Whereas my team are able to log on and look across all of that public mental health data and collect data from all of that.
Oh, that's great. That changed since I was there.
Yes.
So does every suicide get investigated?
Not every suicide gets reviewed by my coders and all of the data put in, but as far as producing an investigative report, there's different levels for which we do that. So it wouldn't be everyone. We do an internal rapid review for about 30% of those that come to us. Those ones are flagged. They are people of particular vulnerability, so children, young people, those who've recently left an emergency department, Aboriginal people, and people who've been identified as severe enduring mental illness, plus others that may come to light in my team where we've had concerns. We then move on to a timeline review internally for another smaller portion, and then if we feel that there's need to review, then I review it with someone else from my team and we produce an internal report. And if we feel that doesn't meet the need, we then go to an external reviewer who does a much broader report and will speak to the family. And we do about 5 of those a year. But the rest of them all have what's called a rapid review, and those that are more detailed, we probably look at about 50%.
Right, thank you. You mentioned DCP records as one of the areas. When you've got an adult death, can you get data that says that person as a child was part of DCP, or is it only their role as an adult?
Yes.
Does that make sense?
The short answer is, yeah, it does.
Okay.
It does. So we have just been having some initial discussions with our Child Death and Serious Injury Review Committee, which is CD-CIRC in my state. And a lot of the young people they look after are Department of Child Protection young people. We, at the moment, have only just been able to start sharing information with them, and that's just due to a change of their ability to share based on regulation requirements. At the moment, can really only get the DCP information if it's a child, where obviously actively it's documented in the files we can see, or they're an adult and then information in their file talks about their DCP experience and what that looks like. At the moment, we're unable to actually look at adults' DCP files, and that's kind of tied with our cross-organisational sort of sharing policies. And at the moment, I don't have the power to reach into that unless it gets to the point of us doing a really significant review, and then that goes through like a ministerial request, which we haven't pursued yet. Again, under our new bill and our Act, there's the potential for us to be able to ask for that, which I think would be incredibly helpful. You would know the risk of self-harm and suicide in people who've been under child protection is significant, is absolutely significant. And that's one of the important links. We also know from a mental health perspective, many of those young people's relationships forever are changed and damaged, and they're more likely to be vulnerable to exploitation, sexual abuse, financial coercion, all those sorts of things. So there's a potential to map, what that looks like, but also intervene. And I think that there's some good opportunities for that, but it does require that information sharing. And of course, remembering all the people on my list have passed away. So obviously I can't get anything contemporaneous. And if you've been in DCP care, we don't have family who've known you well to kind of know that information. So it becomes a bit of a vacuum.
Thank you. I'll ask one more question, then I'll hand across. But I understand that the suicide register in South Australia is underpinned by legislation, and that's maybe not the same in other states. Can you talk a bit about what the pros and cons of that are, if there are any?
Yeah, so I think that what are the pros? I suppose that having the suicide prevention legislation enabled us to develop a statewide suicide prevention plan, and what that does is give us an entire framework of how we want to help all of our community have decreased suicide rates. And everybody, when they think about legislation, employment, wellbeing, they always think about how does this affect mental health. So I think that enables us to have, the reason for a strong suicide register, because it then can drive where the problems are in the community, and it also gives us legislative, regulative ability to actually look at information and ask the questions that we want to ask. I think that it is very difficult to run a register when it's not in legislative structure and framework, and that's because we're asking for highly sensitive information and we're looking at highly sensitive information. and getting those consents and pathways across local health networks and districts and all kinds of things, potentially you'd find yourself having to kind of seek that every time you wanted information, whereas my coders are able to feel safe under the framework and my data custodianship to be able to do all of that in the team that we have. I think that as well, we have a good relationship and understanding because of the legislation of what the register is and why it's important. So people know my team and they know what we're asking. And I think, again, if we weren't under that framework, we may have to continue to explain that each time. So I'm quite grateful for that. Obviously, it's a lot of work. You would know once something's in legislation, you know, the requirement to meet, everything is there. But I have an amazingly committed, really small group of people that run this. They do a great job, and I don't think we would have it if we didn't have the suicide prevention legislation.
Thank you very much. I'll cede to the Deputy Chair.
Thank you, Chair, and thank you, Associate Professor, for your evidence and taking, I think, your valuable time. We know the important work you do to sort of enlighten us about some of these matters. You know, it seems from the submission you've made and what you're doing in South Australia. I mean, I'm from New South Wales my whole life, but it does seem like you're a leading jurisdiction in this way. You do seem to have a better system and approach that you'd kind of want to see in other jurisdictions around Australia. So in that regard, one of our passion projects here in Canberra is the Federation, obviously, and how it works together in states and how you can coordinate. So I always ask these questions of officials in different state jurisdictions. Taking all the work that you're doing and the the need for you to work across these state borders, what processes or how can we help in trying to make these standards more uniform nationally, consistent? And I mean, I know you're doing that with your colleagues interstate, trying your best, but, you know, we're all militating against several different coroners, different legislations, different departments. What is it we could be doing here to help you make those standards at the highest possible standard, nationally consistent, so that the integrations could be a lot better?
Gosh, that's a good question.
I know.
No, it's great. I could talk to you all day about that. You know, what do I think? I think that you would probably know that, so as the group of chief psychiatrists and the national psychiatrist, we all meet and we're trying to find some uniformity around a way of which we report a number of things. So at the moment, in our Safety and Quality Committee, we're looking at sexual safety data and how that's collected and what that looks like. I think that being able to have a structure that would allow us time and energy to do that with suicide registers, you know, marry together and look at, you know, a national kind of data set and uniform collecting would be incredibly helpful. Remembering that when we developed our suicide register, there was a group of sort of 5 of us sitting down as really senior clinicians and working in the department going, what is it we see in people? What does the data tell us? But at the time, this was the beginning of COVID, and so the thought of meeting and talking to anyone else about this data sounded completely inappropriate because everybody was trying to battle COVID. So our ability to engage with other places around a suicide register just didn't happen. I'm really fortunate that I think we ended up developing something really robust, but I think we all developed our registers in that similar kind of time frame. So we haven't had the ability to get together as a group and match that. So that it would, you know, if I think about what would be helpful from a national perspective, would be an avenue where we're able to replicate that and have time and be able to get a uniform data set. Some of the other challenges are around access to coroner's information and the timeliness of when that occurs and the time length. You're probably aware better than I am around some of the delay in those pieces of information and the delay to inquests, and I'm not criticising coroners for the timeline that is, but if we really want to get contemporary data, which is what we know we need from suicide registers, we need to have a really transparent process of sharing during that information pathway, because it doesn't feel as though we're adding a lot if we're waiting 3 years to really find out some of the information that perhaps was known somewhere else. We're fortunate that our coroner, we have a good relationship with them and data sharing with them, but I know that's not mirrored in other places. So again, that makes our data set not the same as other people's data sets. I would really like, I suppose, support in the legislation, support nationally for us to have complete data sharing, information sharing ability for my register. So I'd like to be able to ask Department of Child Protection. I'd like to be able to ask, SAPOL for information relating to that. So we know that a number of, and I'm going to say women because they're often the people who are at the end of domestic and family violence, they may ring police or contact, help for police maybe 15 times before there's an intervention order. And so if I'm just looking for whether an order's in place, it will tell me whether there is one or not. And I can't go, oh, well, there isn't one, so she didn't need one. So I've got some unclear information with regards to that. And I think that's what my health service were highlighting to me. They're seeing the women, in this early pathway, pre-approaching any official pathways, and I can only log the best I can find. The other thing is that our health teams have tried to develop, these risk frameworks to look at really helping decrease suicide in domestic, family and violent settings. Those are very hard to get off the ground because women's health and women at risk in our community, I don't think has been recognised in the way it has been for a long time. And so we could probably provide a really good intervention if there was a way for that to be recognised as a national need, not just suicide prevention, but safety encouragement and safety for women, and having that as something that all women are asked when they have any contact with health services, that there's a uniformity to that. That's a short answer to a complicated question. Then you go, Mel, what do we do then when she says, she needs a shelter and I don't have a shelter? I can't answer that one for you. But if you want to not have them on my suicide register, that's the spot to intervene, because ideally that's what I'd like, is a shorter suicide register with not so many people.
Yeah, no, thank you. Look, that is an excellent answer to a very difficult question, and you've got to several matters. Some of them we're looking at. I mean, the coroner stuff we're aware of. We're dealing with different coroners, hearing evidence from them, and often they want the ability to share data better as well. So, we're sort of, so that's ongoing, but thank you for that. In terms of you mentioned the National Avenue, and I won't interrogate you all day about these sorts of things because, as you say, this is a long conversation. But while we're here, and you're speaking of this, I wouldn't assume in Canberra anyone knows that you meet as psychiatrists. I just wouldn't assume that. I think there's so many processes that rely on states cooperating with states or relationships between key people and key figures, but they're not linked up. That's our federation often. I'm wondering, that National Avenue that you spoke of, you mean a formalised process basically with the federal department and your departments and your body to regularly meet about the standards and improving them. You mean something of that nature, don't you? Is that what you're speaking of?
I do. I think that we have a safety and quality group, which is the chief psychiatrists and some of the deputy psychiatrists, and I think I've just become deputy chair of that. And we meet, and within our own teams, we're putting together, and Dr. Sophie Davison, who's obviously the chief psychiatrist, oversees and runs that. And we, I think will produce a really good, robust piece of work, partly led by the Victorian Department, so the chief psychiatrist there and her deputy with regards to sexual safety standards. But I think that's come about from obviously us as collective and, trying to work out how we can best serve the Australian people. But if there was a more kind of structured means by which we're able to meet, store the information and not kind of rely on kind of the more informal kind of pathway that we have at the moment, I think it would be more robust. And then my avenue to share information and assess its validity, I think that's a challenge at the moment across Australia.
Yeah, well, thank you for that, and I appreciate exactly what you're saying. I won't ask you more questions today. I think if you think of anything there in that pathway that makes sense and you want to pass that on to this committee, I think we'd take that very seriously. I would, and I know my colleagues would. But I might let others interrogate because I accept your evidence that we need better pathways. That the Federation is this project that still we all struggle with, and I think what you've mentioned about sharing data, particularly across different agencies in different states, is still the key piece to unlock, as you said, as early as possible. So we take that very seriously, so thank you.
Thank you.
Thank you. Ms Clubberham.
Thanks, Chair. Thanks very much, Associate Professor Turner, for your excellent analysis, and just the quality of that data, I think, is some of the best that we've had in this inquiry, so we're very grateful for that. I had a number of questions that are on slightly different topics. Just firstly, I can't remember the number, but I think it was 1,400 rough, suicides, and then there was different percentages falling into different categories.
Yes.
You mentioned that a particular number had an interaction with legislation, and I just wondered, what does that look like? So take, for example, the Children and Young People Safety Act or an intervention order. What might that look like in terms of someone having an interaction with those legislative regimes?
So what we did is we pulled out the parts of the legislation, and this is sort of what we considered was an appropriate approach, bearing in mind we didn't have a framework. So it was sort of looking at when had someone had an intervention order in place, when had there been the child safety order in place. So the pieces of legislation that indicated a risk to the person, or the person being a risk to others in the point of, safety, violence and an increased risk of self-harm. So what we pulled out was if that is actually known, so that's kept in part of our coroner's data here, and apologies, I'm unsure what's kept in other states, but parts of those, this person had an intervention order against X, that will actually be known to us in the way that the information is transmitted to us. And the same if it's a child and there's been protection orders for the child. So the challenging part is around that information sharing is I don't know all the details around that. So when we say interacted with legislation, we know that's in place, but I won't know that maybe there were 6 applications and 5 were declined and so on. So that's where some of that information is missing. So I can't say a lot more other than it's there, if that makes sense. Like I don't have the story behind it.
Okay, understood. So in terms of a risk factor, the risk factor is purely the interaction with the legislation. There could be others, and with more unpacking, okay, so why has someone had an intervention order? Why is there a child safety? Yeah, so there's a whole lot of layering that could identify the risk factors. Yeah.
And sometimes we'll know that if you're 16, let's say, and there's lots of information in the health notes and I can see in detail, your caseworker's written a lot in there about you, I might have that. But if you're a woman who's only had 3 interactions with the health service and there's nothing in there about that, but that I see that there's an intervention order, I've got a gap that, we can't fill, but we still think that it's important that we actually document that because it helps us look at when those legal contacts will have been opportunities potentially for an intervention.
Yeah, no doubt. Yeah, okay, thank you for that. My second question is just about, you mentioned I think it was 30% of cases you do a rapid review. I think that was the term that you used.
Yep.
What does that mean? And what do you do with the results? And I guess not so much what do you do, what would you like to do with the results, and what are the barriers preventing you from doing what would be useful with those results?
So in my, probably helps to explain my team a little. So I have a safety, quality and risk team who we share a lot of analysis of very complex cases, so self-harm, suicide, community treatment order, that kind of stuff. And all of those are clinicians. So they're all very senior mental health nurses. And so that team, as well as my suicide registry team, what we'll do is there'll be an update from my coders where all my epidemiologists, when they feel there's a concerning case, and from my epidemiologists when they think there's a cluster, those get highlighted to my safety and quality team. They then move into our all the notes that we're able to access because we can see all the electronic health records. And then a rapid review is essentially looking at either 12 months to 2 years of that person's life and then mapping it out on a very sort of rough timeline, but then in particular looking at the last 6 months prior to death. So that looks at presentation to health services, mental health services. It looks at the actual physical notes. They read all the entries and they pull out key terms, medications, drug and alcohol use, presentations, narrative to SAPOL. My team from the suicide register will be able to see if there's been some of those legislative processes in place. And we're able to see if there's interactions with the drug and alcohol services as well. They pull all that together as well as the demographic data and the data from perhaps where they're located because that helps inform rural, regional, remote, Aboriginal, Torres Strait Islander or very vulnerable elderly or child. That all then comes to me, and then usually myself and another senior clinician make a determination whether from the rapid review we're going to do what we call a timeline review. We've invented this, so you're not going to probably find this in other places, but a timeline review is then when my team will sit down and look at almost 6 months of much more detailed timeline, and that then in itself, we keep that information to ourselves, and we will communicate with the local health network if we actually want further information. They will be completing, if the person's died within 6 months of contact by suicide with the health network, they'll do their own clinical incident brief, a CIB. That comes to us as well. So we accumulate all of that, and then my job is to look to see if there were preventable factors, whether the health provision that was healthcare provided seemed appropriate, whether the normal, safety and quality measures have been completed, if they were involuntary, whether they receive the care that's appropriate. And if I feel that hasn't been met, we then do a full review, which then becomes about a 15 to 20 page, quite thorough analysis of as much of the information as we think is appropriate for that person. So we can have anything from 10,000 pages to 5 pages. That's what they look like for us. We're continually refining that process as we get better. And I hope that answers your question.
It gives an excellent insight into how much work and detail goes into a rapid review. I guess I was getting at more, so if you found a preventable factor, for example,
yes,
what do you do with that, and can you do what is best practice with that? And I'm getting to, obviously, that the research and the in-depth analysis you're doing is excellent, and it seems to me like it can really be used to good to prevent other additional suicides, right? So what do you? Who do you ring? Who do you write to? What do you do?
Who do I write to?
Yeah.
So if we actually come to the end of that analysis, we always share that with the local health network provider. So if we've done a rapid review and we've come up with a summary, and we read their clinical incident brief, they will have recommendations from their own brief if they feel they're in place. And if we come up with recommendations, we share it with them, and they use it as a quality improvement piece.
Okay.
So it might be increased training, review of their education, discharge planning.
Yeah.
If we find it's a cluster, we then actually put together a report, and that goes to the CEO and the head of mental health in that region with the same list of recommendations, and I require a reply with the idea that then stays as like an open action that they need to then feed back to me as the chief psychiatrist of what they're meeting. Mm-hmm. If the next step, if it becomes an external review, so it becomes like we're quite concerned there's been multiple missed opportunities or real deviation, that then actually becomes a report that goes to the minister, goes to the chief executive, and goes to the CEO of the local health network. And that then actually becomes a piece of work that, based on our Towards Zero Suicide, if a family's involved, they come and meet with me, they come and meet with the team, and we do a full transparent debrief process. They'll have contributed to the terms of reference, so we'll be working together, and then that then goes back to the local health network to then embed the changes and feedback to myself, and then I then feed back to the family.
Yeah.
So we try to close the loop with each of these things and not leave them kind of loose.
Yep.
It can be a challenge with a small team, obviously, but that's the ongoing work we do.
That's a great segue, great answer. So I've got other questions. I'll just ask one more, and then I'll give my colleagues an opportunity. So that sounds like a really holistic process where you can get some sort of genuine and meaningful outcomes that might be used to assist clinicians, frontline staff, legislators, policymakers, etc. And I'll probably ask you to take this one on notice because it's a big question. What can we do at federal government level, but maybe also state level, given given the lack of harmonisation currently existing? What can we do to facilitate that process and I guess make it more likely for the gaps, issues, whatever that you find during the rapid review to be adequately dealt with that eye on prevention in all different disciplines that you touch on within that review? What can we do?
I'll take that on notice because I think my team would be absolutely busting to share information.
We would love
that
to
would
hear
be very
about
informed.
that. Yeah, terrific.
Yeah, thank you very much. I will take that on notice.
Thanks,
thank you.
Thanks, Chair.
Terrific. Thank you very much. Ms Whitty.
Thank you, Chair, and thank you, Associate Professor. I have, when we think about the federation model and using you as a gold standard, if we were to bring this into the federation, what things did you learn in the beginning that we could sort of draw from it immediately without having to make those sort of early on mistakes, or what things would you like to see improved on?
Yeah, it's interesting. I keep thinking about the first meeting we had for our suicide register, and it was me and 3 people with a cup of coffee going, goodness me, you know, how do we do this? Which I think is maybe where, you know, perhaps why some of this turned out the way that it did. So I think it became a very iterative process and an awful lot of work for a small team. And I think learning from what we're doing would be greatly helpful for those people who are starting now. We literally sat down and talked out loud about all the things around a suicide death that we thought would be important to know, and had to work by hand using an Excel kind of spreadsheet documenting for some time until we could finance a database. So I suppose what would be very helpful would be, I would really like, if we could, a unified data set that every state collects. And the model of care that, when I was the chair of VAD, that we used to use, where our chairs of voluntary assisted dying boards and our operational leads would actually meet regularly every month to actually talk about data sets and data sharing and standards. And that really keeps the standard of this data collection quite at really high fidelity, but it also improves the ability to debrief. So the other thing that's helpful probably for your team to know is these are incredibly distressing things to read. And I'm asking my staff and my coders to read in detail things including suicide notes, really awful scenes where people have been found dead. And so suicide registers are an incredibly high psychosocial wearing space for people. And so we're asking people to read incredible detail and be really, you know, distanced from it, and you've got to find some very special people to fit that. And so I think that providing a scaffolding and federal community for that is crucial for you to keep the staffing that you need to keep this running. And that the other challenge is that it would be really helpful to have the same database structure where everybody can enter and analyse this data without everyone having to do everything manually. So it's probably important to know that this data, even though we've got a really good database, looking through everything manually and reading the notes and so on is still what my staff do. And so if we had a pathway where, you know, there was federal support to develop like a gold standard way for that to be stored and analysed, not only could we do more, but we could pull data a lot quicker. So, you know, a member could say, I'm really concerned, I think there's been 3 deaths in the Upper Murray. At the moment, I contact my team and they literally go through the database and they can pull the data and give me a summary. It takes them a few hours, and I would love to be able to give you something quicker. I'd love it to be really responsive, and I think then I can provide better prevention. I suppose that the other pathway is that, as Mrs. Miller-Frost was saying, that, you know, having the Suicide Prevention Act has been a really important framework for us to be able to provide this. I'm not saying every state has to have one, but it's kind of thinking about if they don't have one, what's that register run under, who manages it and looks after it. The learning from us is that we started with the register before it was called that, so when it was just called the Suicide Data Bank, I think, when we started, and then it moved to another part of health. It moved to preventive health for us, and what we found that we lost is that without the mental health lens and without clinicians, it really lost its meaning, and the data and the interpretation changed. And so we then asked for it to come back under the Office of the Chief Psychiatrist, and then we're able to really, you know, bring it to the level that it's at now. So my suggestions would be that wherever this sits in any state, it must sit in a space where the humans reading it can understand it, because it is a lot of raw data, and you can't give it to the person doing the, you know, road traffic data collection. You know, like, it's not that sort of, it loses its richness. remembering that qualitative and iterative work is going to be permanent in this space, and we need people who can read into that information.
Do you think that AI has a role to play in this data collection, or is it very human-based?
I would say at the moment, I just don't think AI has grown up enough. I feel like it's a kid, right? So when it's 25, maybe, the problem is it oversimplifies what you read, and that what we know is that, Mrs. Smith reported multiple episodes of distress around her, partner. And then we can then read later on she had a broken arm and later on this happened. And so then there's something about the human reading a timeline and interpreting when she showed up, the time, that we can't get AI to interpret yet. But I do think AI in our database could be quite helpful. You could search for things with that is behind in an algorithm, right? Faster than we're able to do it at the moment. But I think, as time goes on, it may become more applicable, but I think its errors and its own internal, the AI hallucinations, I think would put it at risk of it coming up with things that were non-linkage. And remember, the numbers are little, right? So then a cluster for us is 4 people. We'd only need AI to stuff up 2, and all of a sudden we wouldn't find a cluster. So, yeah.
Yeah. And just one more question. The work you're doing, the information you get gathering, how is that leading, or how can that lead to prevention?
Yeah, so we run the suicide register, but we also lead part of the Towards Zero Suicide Prevention education and training. So part of that is connecting with people training. So part of our prevention is there's a particular local health network here who had a particularly negative incident where we did a quite large external review. And as a part of that, my team have now gone in and done a lot of that connecting with people suicide prevention and assessment training. But we also, when a cluster is found, we actually then link with Preventive Health SA, and they do post-intervention support, which then also becomes prevention support. So we know one of the risks of suicide is having someone die of suicide. So post-intervention, particularly rural and regional communities, that's when there's actually increased money going to services that do counselling, visits to school, visits to Aboriginal Torres Strait Islander communities. They also do different suicide intervention services run by NGOs such as Wayback, and a number of call lines and phone lines. So that gets increased, and then we then meet with the suicide sort of community network, prevention network, and we then do a Zoom meetings where we actually go in and we look to see what other prevention needs to occur. The challenge is the balance of those social determinants of health, yeah? So I wish I could provide housing, and I wish I could provide cheap transport, and all those sorts of things. So the flip side of this, and which some of our health services, talk to as well, is around, true prevention is trying to provide safe legal responses for women, safe housing options for women, and also, part of the legislative, response to the 100 awful texts that you get from your ex that are very frightening but aren't enough for you to actually do anything about. So we know that part of, in this population, prevention also ties into those legal and safety responses. We also have a suicide prevention action plan here in South Australia. So each of the departments have had to put together a suicide prevention plan, which my little office is meant to help oversee. And the idea is that we're trying to help each of those agencies. Each time they're developing pathways and plans, suicide prevention has to be at the forefront of how that affects the community. So early days, it's only been around for a few years, and they've only just had to submit those this year. But now each of my hospitals need to have also redone their suicide prevention pathways. So this year and next year, my office is trying to help everyone understand suicide risk assessment and risk formulation, which we know, if done well, really decreases suicide. So that's our next piece of work.
Thank you. No more questions, Chair.
Mr. Ng.
Thank you, Associate Professor Turner, for taking the time to share your expertise with us this morning. I suppose further to some of Ms. Woody's questions about learnings that you've had. It sounds like, as others have noted, that you're further down the path with a lot of this data collection. Now, we've heard a lot of evidence about some of the sensitivities with balancing privacy concerns and with survivors being comfortable disclosing with being able to collect data. It sounds like health records, child protection records and corrections records you've been able to gain access to. I'm wondering about family violence services and even, I suppose, mental health supports. How have you balanced some of those sensitivities with privacy and being able to collect that data? And what are some of the learnings that might be able to be taken into other jurisdictions with that?
Yeah, no, it's a good question. So any of our, and it's partly, I think, because of our digital health record. So if you go to see our the trauma services that I spoke to you about, that's a public health service that types into the same set of notes that my team can read. If you go to a child health service, they type into the same notes. So we're able to see a lot of that information a lot of other states can't see. What we can't see completely, however, is non-government organisation records and private records unless they're referred to or someone has sent a report into our system, or it sits within kind of the coroner's purview and then it's shared with us. What do I think? I think that so sitting in this space, I've had clear when we read the notes of someone who's died by suicide, sometimes in those notes will be information that that person never wants their information shared with anyone in their family. And I really respect that. I mean, just because someone has died doesn't mean that their wishes, disappear. However, there's also lots of them that you read where there's no comment made in that at all. And so then it's the weight of, we try to release, but I think that being able to look into these notes is quite crucial. I think then we need to be responsible for what we release to anybody else. So if I'm able to give a version that doesn't actually breach the privacy of the person, but is more about factual gaps in practice or deviations from standard or missed opportunities, I think finding out the information, which potentially may happen in my new bill, I think that will really inform this. And the other thing we're missing is schools, right? So we do know a significant portion of children who interact with Department of Education that the school might actually be concerned about the mum, or the school might be concerned about the child. And some of those first early signs, when you look at the data, is around those interactions where mothers are picking up children and dropping children off. And of course, we can't go and interview and grill everybody. But at the moment, I don't have the opportunity to ask. And I don't have the opportunity to look into some of those other NGO settings that might have had contact. And it's a balance between, how much can I just go and ask everybody for whatever, and how much do I rein in? And it's a challenge, right? Because we want to do as much as we can to help these people and meet it early. So I think I try to find a balance between what are the most likely places they've gone to. I'm fortunate that I can get most of my information from the notes I have. I have excellent staff, and that makes a huge difference with what you can glean from the notes. And then those that I think there are gaps, when we then do a wider review and we talk to family as a part of that review, that is incredibly helpful. And that's where we often fill a lot of these gaps.
Sure. And just to confirm, are you saying that you think it would be appropriate or even feasible to have powers to be able to get that information from schools or even non-government organisations, or do you think that it wouldn't be advisable to go down that route?
I would say that, I think it's feasible. The numbers, every death by suicide is a very sad death, but it's 230 people. So let's say my team looked at those and we wanted to know extra information for 15. I think that's a very small ask of the community to prevent suicide. So I think it's very feasible, and I think there wouldn't be a particular reason why some of that information couldn't be shared, except for people then being very worried they're going to be in trouble for missing that someone, they'll be in trouble for missing that someone's going to die by suicide or is at risk. And that's that fear. People are worried about being in trouble for that, whether it's in court, whether it's being sued, whether it's whatever it is. And I think that's the It's the absolute hesitancy of whenever you ask people for this information. So it would have to be a fine balance between them feeling safe, whatever that looked like, to share. I think if they felt safe to share, they'd be happy to do it.
And with data, often marginalised groups might be underrepresented in data. Culturally and linguistically diverse communities, or LGBTIQ plus Australians, or Aboriginal and Torres Strait Islander. Is that something that is coming through in your data, or is that something you've been able to overcome?
Yeah, I mean, you would know. So Aboriginal people are definitely overrepresented in our data. I don't know that I have those specific numbers. The numbers become quite small in this subpopulation once you break it down, obviously. So, you know, we try to remove that. But Aboriginal people still are overrepresented. Rural people are overrepresented. LGBTQI plus, I'm unsure if they're overrepresented in our current data. But I suppose that you'd need to identify that in their notes, and you'd need to sort of know that. So remembering that isn't always written down, and people don't always disclose that to a number of their health providers. But I think that so as an Aboriginal woman myself, like trying to work out how to best serve my community and how to provide what they need, that's a whole day's worth of meetings, right? So part of working out what they need, it's quite different. So consent isn't singular, it's based on a group. Family is a lot more people. Mourning is different, postvention is different, prevention is different, you know, connection, community, country, you know, those don't feature in any of the discussions of our legislation. So whenever I want those to be a part of what we do, that's a completely separate piece of work. And we are doing that at the moment, working with our Port Augusta community, our northern South Australian community. And so they are overrepresented because we don't really have a very good way to support them in the way they need at the moment. But we are trying, so all I can do is keep giving it a go until it gets better.
Sure. And have you found it more difficult sometimes to get, I suppose, data on some of those marginalised communities?
Yeah, so you're right. It is. So there's a lot less of those marginalised communities coming to public mental health or coming to public health services. So that limits what we can collect. We need to think about Aboriginal data sovereignty and where people want their information shared and what they give consent to. Obviously, our legacy of stolen generations and people displaced is that trust is limited, and so there are times where being able to share data will be a no, and we need to be respectful of that, but we need to not ignore that. And we also know that our culturally and linguistically diverse people don't always find a match for what they're looking for in our mainstream health services, so they're seeking supports in different ways, and we don't have a great way of looking at all of that, again, without looking incredibly nosy and over interested in people's personal business, because culturally people's death and mourning and what suicide means for them can be quite different. And we haven't really been able to tackle all of that as we, best we can at the moment. And I would imagine as numbers move on and we can get a better idea of what that looks like, numerically we can probably do more. And, the towards zero suicide and connecting with people fits with a lot of communities and is used in different places around the world as education and training for suicide prevention. So if that was able to be provided a lot more than I can do at the moment, I think that would be a good prevention for a lot of spaces, and hopefully then less deaths, and then I need to worry about collecting less data.
And I suppose in that prevention space, and this is a bit of a broad question, but have you noticed particular times or particular high-risk periods when people are falling between the cracks?
Any point of transition still seems to be one. So, moving from if you're a child in DCP, so child protection, and you're moving into adulthood, ongoing follow-up healthcare, mental health care, increasing self-harm and suicide attempts occurs at that point. We also find that there's a higher number of people here in Adelaide when we have a large amount of substances delivered at particular festival events, we find substance use drives a lot of significant self-harm and suicide and end of life. Leaving jail, getting out of prison is a high risk point. A lot of people who are moving into homelessness from that is quite a challenge. And then generally speaking, probably this particular factor, so domestic family violence, is that a crack that you fall into? I think it is, because I think the risk of you seeking help is as much as the benefit you might get from seeking help. So every time you reach out, if it's not met completely what you need, you then have to go back to a perpetrator. So I think that one of the slipping through the cracks is that I do wonder whether a number of these women just can't find a way out anymore. And we know that entrapment and hopelessness, those two things. So Rory O'Connor's got a great model of drivers for suicide. And we know once you've got those two and you can't see a way out, it's very difficult for people to move beyond suicidal plans.
Thank you, Associate Professor Turner. Those really valuable insights. That's all from me for now.
Thank you.
Mr. Gregg.
Thank you very much, Chair, and thank you, Associate Professor. Your submissions talk about the value of having a taxonomy or kind of a shared way of categorising things. I was wondering if you were confident that you've been able to establish that in South Australia, or whether that's an ongoing project in and of itself.
I think that I think we've advanced a lot from where we started at around the table with a cup of coffee in 2020. I think that our taxonomy could definitely be further refined. So, bearing in mind that when we've had to look at things like Department of Child Protection contact, what does that really mean? We can only find out if there's contact, but there's very difference, isn't there, between child removal and a phone call that goes nowhere. And I do think if we separated that out, we could find more. The flip side of a more detailed taxonomy is access to more information. So I won't let my team have a taxonomy going into minutiae that we're never going to find, or we find in one person and the other, 220, it's never there. So it's always got to be meaningful. And I needed to make sure, as did our team, that everything was tied to something that identified a risk factor, was something that was going to be of meaning to people, and that we could look at in enough of our cases to give us a substance of epidemiologically where a cluster was or not. I would imagine, like any good data set, you need to, and this is any national data set, you need to keep revisiting as time goes on, because new things will come up. So maybe threats over social media will be something in 5 years' time that we haven't looked at but will start being identified. Maybe we'll get an increased opioid drug use in South Australia, and that will be something definite. So the other, part of this iterative process, and that's why humans are so important, is that if we get new themes coming through, we're able to look at how common that is, and then we can consider that being another variable. Then, of course, it moves it away from a universal variable set. So then I have to have clever data people who can then do something with that piece of data. But I do think what we have is very good at the moment. Is it perfect? No, I don't think it's ever going to be perfect, because that would mean you think you've finished. And I think it's, I think it's continuing. You've got to evolve with the population.
So kind of linked to that, I guess, need for consistency, you're also talking about the recording of things at a service level with police and health professionals, using terms like family problems and kind of very vague phrases that could mean a whole lot of different things in different contexts. Has that work begun in terms of training up the police and other service providers in using that language in a consistent way with a shared understanding?
We have shared meetings with, so SAPOL's our police and SAS is our ambulance here. So we have shared meetings with SAS and SAPOL, every month. But my actual team also have individual meetings with different groups of them who look at the data, and they also meet with the coroner as well. So I think there's a better understanding of how important the words and descriptions are. As you probably know, the police force is an incredibly diverse group of people. And so what we find is that it's the accumulation of all the information that helps inform it. So if there was one statement of, challenges within the relationship, that wouldn't go as domestic violence. That's why you have people read it, they look for those repetitions. I do think that our SAPOL team are they're very keen to understand this data. They've been very honest in how overwhelming and distressing it is for them to attend a suicide and what that's like for them and their team. And so they have a real vested interest in this being a helpful tool as well. But it also, we print this in our annual report as a summary, and we can share it with both SAS and SAPOL to inform their education and training. Have I had the ability to do a really big piece of education and training ongoing with them? The short answer is no. I literally have a meeting this afternoon to meet with SAS because I'm doing education next week. And in SA, that's a lot of what we do. It's we try to build really solid relationships with our other people and continue to work that way. But that would make a very big that would help with consistency of the wording.
So is there something simple like a glossary that people can use for these terms?
Yeah, well, I mean, there is, except it's there's just so much more information that we read. So we would read the entirety of a report of what someone would say. So there's a lot about, the context and the description and that sort of thing that my team read into. I would have to say most of those are pretty good in describing things that we would understand with pretty significant keywords. I think the challenge comes when we had someone the other week who had, 21 years worth of psychiatry or mental health notes. And so, working out what of that you read and what you analyse. So that's probably one of our biggest struggles. But most of our other reports, and we can always contact and ask people as well. So there are times where we've contacted and said we're not sure what that meant or what that was, and that can help inform. We don't need to do that very often.
No. As you were saying earlier, it's kind of a state-based data set. So with public institutions, obviously around the country, different states do things in different ways, but there is an increased reliance on private providers, community sector, health organisations and things like that. So if we're not able to access that data, are we expanding our blind spot when it comes to collecting useful data?
Look, I think that in particular with people accessing non-government organisations and even just with the NDIS and its own framework and how that's outside of our system, I think that we would do a better job if we could have... I'm a fan of really looking at all the data that I can to get the information. The limit that I have is my regulatory framework around what I can ask, what I have a right to ask and what people share. So at the moment, we have a living person who was involved in an incident and we're investigating the care of that living person, and they are able to give me consent to speak to their private non-government provider. But that in itself then becomes like a formal written request. So I think you're right. If I could go to NGO X with my regular letter that I would send to a local government, like a local health network, that would be very good. But as I said, there is the challenge is the hesitancy of providers that are worried that they'll have some sort of sanction or punishment as a result of having someone died under their care. So it is a challenging space, and we do rely on it being documented in their health records or told to us by family members. Yeah.
So in terms of the document and information sharing, we've had that raised a lot in different contexts. Some have kind of raised it in the context of informing practice during the person's lifetime, that different practitioners are able to access it, which means you kind of get the full story. But from what I understand, your evidence, you're kind of more focused on what your office is able to access for the purposes of reviewing death afterwards, so that privacy concerns are kind of less profound, and some of the risks associated with having too many people able to access it, I suppose, are mitigated.
We do look at lots during people's care. I suppose it's just this particular committee meeting was around suicide, but lots of other bits that happen. So I also look after, I'm responsible for community treatment orders, inpatient treatment orders, ECT and TMS, so treatments that are done while people are under particular orders, all of our policy legislation, all that stuff. So we do lots of reviews of people who are living and concerns around care, whether the care was appropriate, people having contact around community treatment orders they don't want, etc., as well as the teams contacting us about people who they can't find for care. We have the same ability to look at all the same notes that we do for people who've died. So that permission is granted to my office. again, we have the same limitation of I could ring and talk to the living person's psychiatrist and have that conversation in a contemporaneous way because of my role as the chief psychiatrist. However, once someone's died, the ability to really have all those conversations disappears because it's not that contemporaneous care for the person, and I have concern about them because it's in a different, becomes that very legalistic setting. So we're not a kind of complaints management service where we are, but we are, for better or worse, the receptacle of everybody's contacts when they feel they've met a dead end at the local health network level. So we do a lot of reviews of live people's concerns as well, continually.
One of the risk points that's kind of was raised in your submissions is talking about times around children and separation and things like that. Is information around family law cases just untouchable for you at the moment?
In a nutshell, yep. Again, unless if a child is seeing child and adolescent mental health and we have information about the child, so let's say the child's died at 14 or 15 by suicide, I can read whatever's in those notes. And often there's quite a lot of information that's been shared around that by virtue of their therapeutic approach. But let's say you're 20 and you had 9 years of that as a kid, I don't necessarily get to know all of that unless it's written in notes that I can read, but also contemporaneous family law for the parent's experience. Let's say I'm a woman and my husband's applying for custody. That is out of, I don't know that unless, again, therapeutically someone has written it in your health notes that I can read. But at the moment, it's not accessible to me.
A final one out of left field. Sorry for the rapid fire. Your submission also mentions practitioner collusion, which is a kind of interesting topic in and of itself. And it was raising that this kind of data sharing might assist in identifying that as a bit of a pattern or a potential problem. Would you be able to explain what that is and what you're referring to there?
Sorry, what was that? I missed that.
Practitioner collusion.
Did I?
I think it was on a page that was referring to the ANROS report. No problem, don't worry. I think it was quoting anyway. It was quoting ANROS. ANROS has recommended that the inquiry focus on suicide threats and behaviours as potential tactics of coercive control to support accurate risk identification, avoid practitioner collusion, etc., etc.
Is it a written report from me?
Yeah, the stuff.
I didn't write one to you. Was that from Tammy Allen, the Commissioner?
Could be from the Commissioner.
Sorry.
No, that's all right.
No. I was going to say I'm unsure what that means. I have to take that on notice and have a read.
No, that's fine.
No, happy to. Okay, thank you.
Thank you.
Thank you. Look, I just wanted to follow up a couple of things. You mentioned that there is some legislation currently making its way through State Parliament in South Australia, a health and wellbeing bill. Can you give a bit of, obviously we don't know what's going to come out the other end, but nonetheless, in terms of what its aim will be and what you're hoping to get out of that, can you give me a brief summary?
I can. So this is really our first review of the Mental Health and Wellbeing Act, moving it to a Mental Health and Wellbeing Act from just a Mental Health Act. It's the range of goals is focusing more on wellbeing, so looking at mental health. We have increased principles around shared communication, supported decision-making, recognition of children and adolescents as a subgroup of people receiving care, recognising other vulnerable populations, including Aboriginal Torres Strait Islanders, LGBTQI+, and other people from other minority population groups. It separates out child and adolescent mental health involuntary care, and in particular talking about inclusion of discussion with parents, carers and guardians and some of the pathways that need to be paid attention to. So the timeframes for involuntary care and community care are the same as adults, but it pulls out the quality and the principles needed. We also have a particular section on a Human Rights and Coercion Reduction Committee, which we're hoping we'll get through, which will actually look at managing levels of involuntary care, advocacy and information around minimising restraint practices. And another part is around information sharing, and that's to do with inspection and investigation of services and to do with the suicide registry. So what we're requesting in it is that we will be able to ask information of any of the agencies that are sitting under the state health umbrella for these particular purposes. Obviously, the idea is that they would only be asked for under reasonable circumstances, but that was to really decrease some of the challenges that we have with accessing information. We have also asked in that bill that we could also ask of information from other bodies, people or services. I'm unsure whether that will be approved. That would mean we could approach an NGO or we could approach a private practitioner, and the Crown solicitors are reviewing our document. But it's already been seen by our Cabinet on 2 separate occasions and has had certain approvals around a range of items. It's a much longer bill than previously. We've pulled out more detail in particular this time. It names having a deputy chief psychiatrist if that's what the chief psychiatrist wants. We're a very small office. I only have 20 people in my office. And then other parts of the bill, we're really trying to focus on human rights, supported decision-making, least restrictive practices, and a focus on wellbeing and the principles around that. So trying to really grasp that prevention, early intervention, let's share information. We've done 2.5 years of feedback and consultation around the process, and you're welcome to look on our website at what some of those feedback pieces look like. And that's been extensively with the ambulance service, our police service, as well as all of our local health networks. Some of the challenges are going to be that we are asking clinicians to write down why they may or may not keep someone as an involuntary patient. We're asking people to share some more information with carers and caregivers as a response from people who wanted to know a bit more about their loved one who was or wasn't admitted to hospital, and to facilitate supported decision-making for people. So if you weren't on your own as a person, perhaps with early psychosis, making a decision that the practitioner would need to facilitate a contact if you wanted someone to help you make decisions, so to ring your mum or your sister or brother when you're unwell. So everybody wants those, but putting that into a very busy system is a challenge. So, and the other part is we're changing the risk of harm to serious harm with regards to using involuntary treatment. So that also means people potentially needing to really only keep people detained under the Mental Health Act when it's serious harm, and so that's a timing of the definition.
Thank you. And will that enable you to access data from other government agencies such as schools? I'm not sure. It
would. If currently, as it is written at the current bill, which at the moment is kindly being reviewed by my Crown Solicitor's Office, then that would enable us to do that. And it was one of the reasons that it was put in, because at the moment we're the only agency in South Australia that does this review to this level of people who've died by suicide. And I think it's very much worthwhile to keep the robustness and the quality of what we have in our suicide register.
Great. Do you have access, or would there be any benefit to having access to Commonwealth data such as MBS and PBS?
I think that in a number of cases it would be very helpful, particularly when we're trying to work out whether somebody's actually seen a local practitioner, because MBS would tell us when they've seen someone. And PBS information, I suppose as someone who's been on PBAC, I always find PBS information helpful, but what it actually gives the clinicians a view is to what the person actually was taking for medication and had access to. And for some of our patients, obviously you would know that the coroner does some of that, but not in depth, and sometimes we're left with a confusing picture about whether someone actually got prescriptions from someone or didn't. And because we try to follow that just towards zero suicide approach with families, and we form a part of that transparency, that can be quite helpful.
Thank you. Look, another really important part of our terms of reference is looking at those intervention points in terms of what we can learn from the suicide data. Do you have any sort of common recommendations that have come up a lot, or any intervention points that you've identified?
So our, I suppose as an office, one of the comprehensive discharge planning for when people leave inpatient unit. So the most common problem is people leaving without a known appointment for follow-up, or people leaving with without a clear path of where they're going once they leave the hospital. So they'll sort of kind of stay with their sister, they think, for a couple of days, and they like their GP and they'll see them. And even though we don't want to be paternalistic, for some people that is too loose a plan to kind of go home with. So, you know, probably that support and scaffolding of, you know, the person actually picking you up. Can we check that you're actually, what's the name of the GP? Can I send them a letter? Have you got the medication that you need? How many days is it for? So we find that's tricky. The other one is people who leave the emergency department without follow-up, without clear follow-up pathways. So one of the other tricky points is waiting in ED. So they're awful places to wait when you're feeling really distressed, and people just might walk out or they stay and then they don't actually receive a concrete recommendation or plan for support. We also know that we need to move away from risk stratification. That's where you tick the boxes, right? High, medium and low. We know research tells us that's unhelpful. So we're trying to roll out risk formulation. It's a psychiatric word, but basically it means the narrative about why did you come here, for what reason now, and what do you need? So it's a much more conversational based approach. And we know that if you do that and you then develop a suicide prevention plan, it significantly decreases your suicide risk. And that can be done any health touch point, GP, child mental health, emergency department. So that's another intervention that we're trying very hard to roll out. The other challenging part is community mental health. Like everywhere, they only take people who meet a particular high threshold for mental illness, and they're not nice places where you want to sit with your kids and wait for your appointment. So we have a gap where people just can't seek the I'm kind of functional, but I feel incredibly depressed and want to die space unless I can afford to see someone in private practice. And that's a challenging space to support people in because they're often declined for public mental health follow-up. So that's a gap of where do people go. And I do think we have spaces for all of those. However, they're not connected. So my barrow is I would love for there to be a resource that tells everybody all the places that they can actually go and it works and it's live. And I've seen models of that overseas because that person who needs support could actually go to Women's Health statewide and she could have an appointment, but she doesn't know it exists. No one tells her that it exists. So, really linking those things up and de-siloing healthcare is what we need to do. So they would be the most common points that we have. And mostly it's not about missing a diagnosis or skipping a medication or, it really is those other follow-up, early prevention, and some of those linkages and social determinants. Where can I be safe? A place of safety is where they need to go, and then someone to talk to, and then someone to help them. It's those three bits.
Lovely. Look, thank you very much. We've reached the end of our time. Thank you for making time for us at short notice.
It's okay.
It's been extremely
And apologies
helpful.
I'm not there in person. I only hopped off the plane from the US yesterday, so...
Don't be silly.
Well, you don't seem jet-lagged at all. So thank you. Now we have a little thing I need to say to you. Thank you for your attendance today. You'll be sent a copy of the transcript of your evidence to assist you with answering questions taken on notice today, and you'll have an opportunity to request corrections to transcription errors. Once you've received the transcript, you're asked to provide responses to any questions on notice within 2 weeks. Please forward these and any additional information that has been requested to the Secretariat. And if you think of something else we should know, please feel free to add that in as well. The Secretariat will confirm these arrangements when distributing the transcript. Please note that responses to questions on notice will be published on the committee's website as submissions to the inquiry. And thank you again. That's been extremely helpful.
Thank you for inviting me. Thanks everyone for your time.
Thank you. Thanks.
Thank you.
All right, I can see that our next witness is online, so I now welcome Ms Pauline Gulliver to give evidence. I think it should be Dr Pauline Gulliver. For the Hansard record, would you please state your full name and the capacity in which you appear before the committee?
My name's Pauline Gulliver, and I am in front of you today in my capacity as Research Co-Director for VINE, which is our National Family Violence and Sexual Violence Clearinghouse, and as a Senior Research Fellow at the University of Auckland.
Thank you very much. Although you're not required to give evidence under oath, this hearing is a legal proceeding of the Parliament. It has the same standing as proceedings of the House. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence today will be recorded by Hansard and attracts parliamentary privilege, although I'm a little unclear about that, how that works overseas. Don't say anything too bad. Let's go with that. I advise that parliamentary privilege may not apply to witnesses appearing outside Australia, and ask you to consider that when responding to questions. I'll just do a quick whip around of who the committee is, so you know who you've got. My name's Louise Miller-Frost. I am the chair of the committee. I'm a member from South Australia in an urban electorate.
Alex Hawke, the deputy chair in New South Wales.
Claire Clutterham, member for Sturt in South Australia.
Mr Gregg.
Matthew Gregg, member for Deakin in Victoria's eastern suburbs.
And Mr Ng.
Gabriel Ng, member for Menzies, also in Victoria and Melbourne's eastern suburbs.
Lovely. And we did have Ms Whitty on earlier, but she's popped off and may come back again. So, Dr Gallagher, do you wish to make a brief opening statement before we proceed to discussion?
My opening statement was really just to acknowledge the Ngunnawal people as custodians of the land that you were meeting on, and to recognise other family and people with connections to the lands of the Australian Capital Territory. I also just want to acknowledge a shared history of colonisation that's shared by Australia and Aotearoa in New Zealand, and the ongoing impact that has on tangata whenua in New Zealand and Aboriginal and Torres Strait Islanders in Australia. It intersects quite significantly with our family violence, sexual violence and suicide.
Thank you very much. So we'll go straight to questions. Can I ask you a little bit about the New Zealand Family Violence Death Review Committee and the report that came out of that, the femicide deaths? Were there any particular findings that you felt were really profound in terms of perhaps points of intervention or indicators that should be taken up by either health or police or government?
Where do you start? So from our perspective, we hadn't really considered femicide as an issue for New Zealand previously. I'm not entirely sure why. Generally, we thought that it was something that was more applicable to sort of Latin American countries where you have a massive overlap between femicide and the organised crime syndicates over there. So for us, it was an interesting piece of work to do. I think in this context, the overlap between experiences of family violence and sexual violence in the lives of pregnant women or women who had given birth was quite eye-opening. Over 60% of our cases of maternal suicide had some family violence or sexual violence history. And given that we know in this country probably 25% or less of family violence is reported to the police, that was quite substantial. I think there was a lot of unknowns that were more critical to us than, or not more critical, but were of interest for us. A lot of unknown information about the impact of tech-facilitated violence, online sexual abuse, the impact of that especially on young people, and the potential unknown deaths that we have as a result of that sort of stuff. We don't have any way of centrally collating that information as yet. We have a relatively high proportion of homicides in New Zealand that are related to family violence, and that was made known to us by our international reviewers of that report. So that's also something that is of concern. And there are some cases there where we still don't know if homicides were femicides, if there was a gendered basis for the homicide or not. So there's a small chunk of cases that we still have uncertainty about. We have the Family Violence Death Review Committee, but other than that, we don't have a central repository for femicides in this country.
In terms of the Family Violence Death Review Committee, are you able to tell me what sort of, something about the processes, where they get their data from, what access they have to public and potentially NGO or private data?
Yep, so the Family Violence Death Review Committee was established through legislation, so we have a relatively permissive legislation. It's initially established through the Public Health and Disability Act in 2010, and a component of that Act allows us to request information from anywhere, essentially, and people are obliged to provide us with that information. We can prosecute if people don't provide us with information. We haven't done. We tend to have a relational approach to the collation of information as much as possible. That Act, while it allows us to gather information, it doesn't allow us to subsequently report on that information in a way that could identify individuals. So while we can collate information for the purposes of a death review, and we can go as wide and as deep as we want, the reports are held very closely, and so the recommendations can be used as long as they're not identifiable, but the actual content of the reports won't be published. So that's quite different from the England and Wales model, where they will republish their reports in full. In New Zealand, we don't publish our reports at all. We do use that information on as the basis for thematic reports that come out once every year or two. So our femicide report was one. We've had previous reports that have looked at aftercare processes and availability of support for surviving family members. We've had, data reports and things like that. So in-depth reviews will be used as the basis of that. Our in-depth review process essentially requires us to collate all that information, look really detailed at sort of things like access to services, response from services. We look at clinical notes, experiences of people who've had through their lives. So we take a life course analysis because with a lot of our work we've found that people's use of services or not is often determined on the basis of the help that they've received in the past. So if, for example, you have a woman who's phoned up because she's experiencing violence or she's in fear of the safety of her or her children, and part of the response that she's received has resulted in her no longer having care of those children, then in future she's less likely to pick up the phone and request support.
Fair enough. And so with your with the Family Violence Death Review Committee and the femicide report, do you include suicide in those statistics as being family domestic violence deaths, or are they a separate?
We did for the femicide report. So we've recently had a change in the function of Mortality Review New Zealand. So prior to 2022, we had 5 distinct mortality review committees. They were all disestablished in 2023, and we now have a National Mortality Review Committee. And the Family Violence Death Review committee became subject matter experts and now report up to the NMRC. What that change in structure did was meant that the Family Violence Death Review Committee were no longer restricted to the deaths that they could review. Previously, it had just been homicides that they looked at. With the change in structure, it meant that they could look at all deaths that had a family violence association with it. So now there's the ability to look into things like suicide more.
Thank you. One of the challenges that we've come across in other jurisdictions is the use-loose of language in terms of being able to identify whether a person has had a family violence background in terms of, things like difficult childhood, family problems at home, not being very clear about what that means. How, when you're looking at which deaths do fall into the family violence, how are you getting that information? Is there a taxonomy? Are your coroners alive to this? Is it police? Who's identifying that there is a family violence background?
Our starting point is generally police. So in the case of a homicide, it's relatively easy. You look at the relationship between the victim and the offender. In the case of the suicides, we start with a suicide death and then we go backwards. So we ask police if there's been a family violence history for that death. So that, as with what you've described, there's less certainty because we have people who have suicided who may have a family violence history, who've been identified as an offender in the past, who've been identified as a victim in the past, who've been identified as both, who were witness to a family violence event in their childhood, and they'll be recorded within the police family violence records as well. So again, it kind of comes back to our permissive legislation that we can get a full family violence or family harm history from police and then be able to work out those suicides that are family violence related. It is a lot more labour intensive than our homicides ones where it's easy to identify the relationship.
Thank you. And in terms of the information that you're getting out of this, are there clear correlations, intervention points, recommendations that have come out? And again, I'm specifically very much looking around the suicide side of things in terms of identifying when you go back into somebody's history, you can see where they had a contact that could have been followed up if people had realised?
I want to say yes, but it's a lot more complex than yes. Yeah. And I think that in part, so there's a few things that sort of tie into this. What we've noticed through our reviews is that the way people describe things is not often the way that they're captured in clinical notes. So a person might describe an experience, they might describe how they're feeling, and then what may be captured within those clinical notes is depression, anxiety, a psychiatric or psychological treatable thing. And the experience that triggered that disorder, if you want, isn't as well captured. And certainly from our perspective, if we started considering the experience rather than the illness, we might get a little bit further along the track. The other thing that we've noticed a lot in our work is the treatment of people as individuals rather than as members of a family. And certainly within family violence field, not considering people within the context of the family is massively problematic. So you might treat an illness again, rather than thinking about the context of how that illness is being experienced. So again, you may be treating the depression while leaving people within a context that's reinforcing that depression because they're still experiencing or exposed to the violence. So we don't think about how we can support or respond to the context within which that illness is being experienced, and that for us is a major problem. The other intervention point, I'm not sure, it might be a way of how we're thinking about violence, and we don't have a solution for this yet, is understanding, I'm going to say men because overwhelmingly they're men, men's threatening suicide in the context of family violence. So if you leave me, I will kill myself. And often those threats are a form of coercive control, but there are also a number of times where those threats are realised and a person does suicide. And as a sector, family violence sector, I don't think we've necessarily got our head around how we respond to that while keeping women and children safe. So again, it comes down to the person within the context of their family, and certainly within New Zealand, that's a relatively major issue.
Thank you for that. That particular issue, that last one, is specifically mentioned in our terms of reference as well. I might just jump straight across to Ms Clutterham.
Sure.
Thank you.
Thank you very much, Dr Gulliver. I just have a couple of questions. The first one is just about the definition of coercive control. So in my home state of South Australia, the state government criminalised coercive control in September 2025. And it's got I guess you'd call it a non-exhaustive list of things that might be considered coercive control, but they really only apply in the sort of current or former intimate partner context. They don't apply to situations where a child might be involved. It just wasn't the intention of the legislation. Do you have a view on what the definition is for coercive control? Whether it's possible to have a global definition that captures everything, I suspect not, or whether, you need different definitions depending on the context. Because I think often a definition can ground where we are. It can anchor discussions and policy if everyone is working off the same page. So I wonder what your thoughts were on that.
My thoughts are that coercive control in particular, incredibly difficult to define. So my understanding of it is it's more about what's experienced than what's used. So you can, I'll explain that a bit better. You can define it in acts, the way people act towards somebody else, and yet some of those acts can be incredibly benign. But the experience of that, how a person responds to that act, might seem completely disproportionate to the act itself. So a look, as an example, and that look means a lot to the person who's at the end of that look. But for people in the surrounding environment, it's difficult to see, it's difficult to understand, it's difficult to feel the experience. So certainly everything that we understand is that coercive control is experienced as much as it is we're really interested in your experience of legislating for it because it's so hard to define. The use of children in a coercive, controlling environment, I think, is it's about as bad as you can get, sorry. Just in terms of the ability to affect an emotional response through behaviours, again, that might look, to all intents and purposes, to be benign, but they are actually deliberate, they're controlling, and they're used in a way to get a response from someone. So I think in answer to your question, no, I don't have a definition. I don't know if an easy definition is achievable. And part of the reason I don't think it's achievable is because behaviours can change so quickly in response to how a person reacts to them.
Mm-hmm. In the South Australian context, it's legislated in terms of acts. So certain categories of acts could be coercive control, depending on the situation. You would have to distinguish that on the facts on each and every occasion, but it's certainly done through that kind of perpetrator act lens. But as I said, it doesn't cover children. That wasn't the intention of the legislation. Okay, thank you for that. I have some sort of just reflecting a bit on that about how governments would legislate and create policy in the absence of a framework or a definition, and trying to legislate on the basis of how someone feels in any given context is an incredibly difficult, almost impossible task. So I guess the South Australian example has been not even a year old, I think, yet, so there wouldn't be enough of a sample size of data to assess whether that's been successful, but that's certainly something that could be looked at also at federal level. My second, sorry, go ahead. Sorry.
Yeah, I was going to say we have examples in our database. So clearly that it's been a homicide that's been the final result, where there are no physical acts that are recorded, but the willful destruction of children's property, the use of animals. Killing of animals, financial manipulation, but all within a context that individual behaviours, as I said, were aside from the destruction of the kids' property and the animals, were relatively almost, I don't want to say socially endorsed, it's her responsibility to look after the kids. I'm looking after the finances. Those sorts of attitudes that in some communities are almost accepted, and therefore it's hard to understand the impact of those until you see how a person is trying to find a way around them or get access to their own finances so they can live their own life. The tenacity of some women to be able to exist even in a context of a coercive, controlling partner, I think is something that is phenomenal.
Right. Thank you for that answer. My second question is just about wanting to make sure I really understand the reasons for broadening the definition of femicide and what that meant, because I had a sort of existing understanding of what femicide is. And I think what you were saying earlier in answer to a question from the chair is that in the context of this report, it could actually include suicide which took place because of coercive control, or coercive control being a factor in a person's decision to suicide. Is that right?
Yeah, we expanded it primarily because there's quite a lot of international research that highlights that more women take their own lives than die through homicide. So we thought that was something that was critical to capture within that report. We thought, and I think it was UN Women who produced a report on measuring femicides, said that countries should consider suicide as part of femicide measures if they could. And in doing so, it also allows us to think about things like tech-facilitated abuse, where it is entirely gendered. This sexual violence that can happen over those forums, and that can be quite destructive to a person's experience of their freedom, experience of who they are, and can result in people taking their lives. So we know of a number of cases where that's happened, and we wanted to capture that as well. So it is, from our perspective, it was still the loss of women's lives as a result of gender-based violence.
And did you receive any criticism of broadening that definition, in the sense that I guess it's not so much blurring those lines between, say, femicide, homicide and suicide, but those are three, to my mind, very distinct things that require very separate and targeted policy initiatives to assist, at all stages of the process. Is it helpful to sort of broaden the definition such that everything falls within it? Because everything would under your definition, or is it better to keep these things separate so that they can be deliberately, considered with targeted policy responses?
I suppose if you thought about prevention and the prevention of gender-based violence, then you'd have a general response to all three. I think once you get I'm sorry, I'm having a debate in my mind as a result of your question.
No worries. And you can take it on notice if that is helpful. We don't, if you need to think about it,
I think my gut response is that if you have appropriate service response to a woman's experience of violence, then I would imagine you'd be able to prevent both homicide and suicide. So that's my general response to it.
Yeah. Okay, thanks. Thank you. Thanks, Chair.
Thank you. Deputy Chair? Mr Hall?
No, I'm fine, thank you, because I just ducked out, so I'll let that
Fair
go.
enough, no problem. Mr Gregg?
Thank you, Chair. A lot of fascinating concepts there. So I'll put a proposition, probably is the easiest way to do it. So my understanding of your report is that it's kind of focused on preventable systems failures, and that in the case of female suicides, that there are kind of gendered drivers on the pathways to suicide, which are distinct from that of men who obviously engage in suicide more often than females, but there are specific contexts that we do need to look at through a gendered lens. Is that right?
Not for all female suicides, but certainly a chunk of them, those that are family violence and sexual violence related, I think so.
Thank you for that. So in terms of the life course analysis, so by the sounds of what you were saying, that's kind of a reverse chronological process. Is there a point where data retention rules and things like that provide a bit of a dead end at a certain point in people's stories?
We haven't found it so far. So a lot of our data sets go back to the 80s, so I guess anything prior to that, yes. We certainly have, for most of our the homicides that we've reviewed, we've managed to go back quite early into their lives. We're not going to go through the minutiae of childhood if a victim was 70, for example. There are some things that clearly you'd go too far back on, and it would just be incredibly hard. I think we have, it would be fair to say that it's easier for us to be able to look at a complete life course if you've got a younger person, so somebody who's late 20s, early 30s when they die. We have fair chunk of our homicides that are around that age. So that's for the remainder of it, I guess we are dependent on recall. So what's captured in clinical notes that people recall from their childhood. So there are some intergenerational violence that we pick up as a result of that, those sorts of things. And we also, weirdly, we can go, back to what the parents of offenders or victims, what their experiences were as well. So it's relevant in part because that situates their experiences within a wider intergenerational context, which is really important. Tells us some things about supporting people as they grow up. Also tells us quite a lot about the supports that are available for people if they have witnessed a homicide in their childhood. And we don't have a lot or any. So that for us is a critical issue, and it becomes even more of a critical issue. Actually, we started talking about maternal suicides, and when we looked at the supports that are available for children who had witnessed a parental homicide, for the females, one of their first contacts with the health system was as a pregnant woman, and she often had a traumatic pregnancy. Not necessarily, didn't necessarily lose the birth, but you have trauma upon trauma, and then you wonder why we have people who suicide as a result. And it may not be because they've experienced violence themselves, or they've witnessed it, or they've witnessed the most serious forms of violence. So that's why we tend to take a life course approach. But yeah, sorry, I almost lost your question now.
No, that's all right. It was just basically how far back can you go in time, and is that always straightforward? But I think you've answered that. In terms of that process, that sounds quite rigorous. How long can that process take?
Yeah, well, that's part of the problem, right? So we don't review all deaths. So if we're going to do an in-depth review, it can take sort of 3 to 6 months, depending on how much detail we've got about the person or people involved, how much engagement families have had with services. So it is a longer process, and it is resource intensive, and that limits the number of cases we can review.
And then at the end of the day, a lot of the report isn't published. Would you say that that's a limitation on the benefits that could arise from this whole process?
Yes and no. Some of the stuff that we review has not been proven before the court, if you will. Some of the stuff that we review is not well known in a family. So some of that information has to be held confidential because, it hasn't been proven and it's not well known. We don't have, in contrast to the England and Wales example, we don't have a support structure that allows families to engage with a family violence death review process, and that's problematic. So if we want families to engage with them, they do it with the knowledge that there's not a lot of support there. We can put them in touch with psychological help afterwards, but there's not that purpose-built support structure. And UK and Wales, or England and Wales do have that, and that's incredibly valuable. Because the other part of that process is that you have advocates that work alongside families that allow them to understand the process, engage with the process, and work out how they're feeling afterwards. And our information sharing is not reciprocal, so families don't own that process. That is, from my perspective, a problem. The flip side of that is that the depth of information that we collect allows us to really, really well understand how people interact with services and what encourages people to interact, but also what creates a barrier for people to interact. And knowing that history that people don't just turn up a service with no expectation. They turn up with a knowledge of what they've experienced in the past, and that really forms a critical barrier for some families about how they're going to further engage and help seek in the future. And it also exposes real limitations with risk assessment, because if you haven't received effective support in the past, then you're less likely to be open and honest for risk assessment or risk screening tools.
Some of our earlier witnesses were talking about how it can often take several kind of well-facilitated interactions before someone's prepared to disclose something. So when you're looking for missed opportunities in your reports, is it sometimes that there just haven't been enough opportunities for people, or that are you able to go into the minutiae and go, was this intervention best practice and it just wasn't a moment for them, or are you relying on kind of vague historical information? So you're just kind of, I guess, applying judgment and cumulative reason to what's going on there.
Yeah, well, we do engage with agencies, so we don't just collect their notes and interpret them ourselves. We work with agencies when we're understanding what's happened. The more recent information we probably put more weight on, but we put that weight on knowing what's happened previously. So when we look at files and how people have been recorded and how that's been interpreted, we do that alongside people who have an intimate knowledge of their systems and structures. So I believe we try and reduce bias as much as possible. There will be bias that is introduced through the process, I don't doubt that, but we try and minimise it.
My final question, and this relates to something that's come up in coronial context. If there is a kind of a court finding in the person's history, given that you're allowed to access information that would probably not be admissible in court and things like that, are you allowed in your reports to come to a finding or review that is inconsistent with the court judgment?
Yes.
Wow.
Right. Thank you very much.
Thank you. Mr. Ng.
Thank you, Chair, and thank you, Dr. Gulliver, for making the time to speak with us today. It sounds like the life course analysis approach allows some really interesting analysis. I was wondering if you could expand, please, on some of the areas that you highlight in your report. In particular, we haven't received as much information in this inquiry in terms of the intersection between, I know you focused on substance abuse and family violence and the risk of suicide. So I was wondering if you could expand a bit on what some of your observations in the report are in that regards.
Sure. Yes, substance abuse is evident, and it is a factor in a number of the cases that we review. I took a side there because there's, the perception that alcohol or drugs causes violence, and I don't really subscribe to that view. I think probably where we do see a really, really strong relationship between substance use and violence, it's with methamphetamine and when people are coming down from meth. And that certainly in a number of cases that we've looked at, there's a really, really strong relationship there between that and child abuse and neglect deaths. So I think that, again, I sort of go back to what we were talking about before, where we see an illness and we treat the illness, and sometimes we talk about substance abuse, or we do talk about substance abuse as an illness without understanding some of the triggers for that, violence being one of them, and people self-medicating to cope with the violence that they're experiencing. And yes, there's a strong relationship between drug abuse or substance abuse and suicide as well. And I think that, and again, until we're able to sort of treat things in totality without picking off one or two components of an overall context that a person's living within, then we're really, really going to struggle to get any further forward. We have a number of, actually often Māori NGOs will take the person and their family and what they're experiencing in its totality and work with them through all of that. And often that's where we see things work out a lot better. You know, people are treated as a human being rather than as a substance abuse person or a mentally ill person.
And would you be able to expand a little bit on that, please, in terms of, I suppose, that individual-based approach as opposed to the more siloed approach? Do you mean that they would get supports in each of the areas that they need?
Yeah.
Service provider or?
Yeah, so you're working on the substance abuse alongside the trauma that they've experienced that may be the reason why they're abusing substances. You might have support for getting away from a partner who's offending against you. That, you know, it's a more holistic approach rather than just treating the substance abuse. Yeah, that's what I was meaning.
And you mentioned that in a Māori context. Is that something that has also been used in a wider context, in a more mainstream services context?
Possibly. I think it's more difficult. So we've got this. So it's called whānau order in New Zealand, and it's essentially you treat the family, or you work towards the well-being of the family unit. So sometimes more difficult to do in a family violence sort of situation where there's a need to ensure the safety of particular people within that family, but that doesn't necessarily mean that the family has to stay in the same house. And then you work with that family to resolve the wider social issues that may be being experienced. And it's a long-term thing. It's not a sort of short-term intervention. So it might include things like housing, drug abuse, violence, employment, you know, those sorts of things. So it's taking the family in complete holistic terms. More often than not, delivered within iwi-based services, NGOs, but they can also draw on the support of government agencies to help with that intervention delivery. So they can draw on the support of housing providers, they can draw on the support of work and income, mental health services if they need to. But there's a person or a key worker that's walking the journey with that family.
So kind of a caseworker or a case coordinator almost.
Yeah.
Yeah.
But for the long term, so not, you know, just a 3 or 6 month thing.
How long term are those interventions?
Oh, you can be engaged with the family for, 12 months, a couple of years, as long as it's needed. And so our previous report, we highlighted a couple of these. So this, if I can provide it to you, actually, it was our 7th report, and we looked. It was called a duty to care, and we highlighted some of these service providers, and that there would be you'd provide high intensity sometimes when they need it, reduce contact when they don't need it, allow people to circle back because they've got a trusted relationship with an organisation in times that they needed support. And then again, maybe you have a few months where you have no contact because things are going really, really well. But just providing that anchor point so that over time families are able to get back up on their feet. And if you've got an extensive trauma history, it's not going to be a straight line to resolving these things. You will have cases where you may relapse, cases where people may lose jobs, those sorts of things where you just need engagement again.
Thank you. And I mean, that's definitely something that I suppose we've heard from other family violence support services, that the recovery is not necessarily linear and that people might need longer term interventions. Chair, if I've got time for another question, or are we?
If you can be very quick.
Very quick, okay. It was also around expanding on some of those maternal child health supports that you recommended in your report, or that you highlighted in your report. If you'd be able to tell us a bit about why you thought those were a particularly important intervention.
Violence in pregnancy is a massive issue, and what we don't have is a really good understanding of the loss of babies as a result of violence during pregnancy. We don't have a way of collating that information, so we don't have any information about that. We do know that there's around 6% of pregnant women, I think, who have experienced violence that's heightened during pregnancy. And in that report, it was apparent that, maternal suicides are strongly related to family violence. And so from our perspective, it's a critical point. It's a critical point in terms of intergenerational transmission of violence. It's a critical point in terms of having good outcomes from pregnancy. It's a critical point in terms of mother-child bonding. I don't know what else you would need to realise that this is a massive issue, and yet sometimes it feels, and I am independent when I say this, sometimes it feels that we struggle to get health to understand how vitally important it is to address violence in pregnancy. And our midwifery services are not set up to do that.
Thank you again, Dr. Gulliver. That's a really important insight.
Thank you. We actually have gone over time, but I'm just going to ask you one very leading question. I've come across some information that looked at suicide and some of the correlations, and for Maori and Pacifica women, there was a very high correlation between school expulsion and suicide within 10 years. Was that your report? And if so, are there other correlations that we should be aware of?
Yeah, we had a suicide mortality review committee briefly. It only lasted a couple of years, and that data came out of their report. So that was part of the Health Quality and Safety Commission. And yes, school expulsions are a massive risk factor for subsequent suicide. And I think rates or the risk would be higher for Māori and Pacific in particular. I could find additional information on that. I don't have it to hand right now.
No, okay, lovely. Look, thank you so much, Dr. Gulliver. I would be very interested in that report, and I think you'd offered to send another one as well. So I'll just do my little closing speech. Thank you for your attendance today. You'll be sent a copy of the transcript of your evidence to assist you with answering questions taken on notice today, and you'll have an opportunity to request corrections to any transcription errors. Once you've received the transcript, you're asked to provide responses to any questions on notice within 2 weeks. Please forward these and any additional information that's been requested or anything you think we should know to the Secretariat. The Secretariat will confirm these arrangements when distributing the transcript. Please note the responses to questions on notice will be published on the committee's website as submissions to the inquiry. And what's our delay in transcripts coming out at the moment?
They have been taking sort of an extra 2 weeks, but
month-ish. Yeah, so it may be 2 weeks to a month before you get the transcript. We've got a bit of a backlog happening here, so please don't think we've forgotten you. It will be coming. The committee will now suspend for a brief break before resuming at 11:30. Thank you so much, Dr. Gulliver. That was really interesting. Thank you. Very helpful.
No worries. Thanks for your time. Good luck on your deliberations.
Thank you. Okay, we're going to start again. We appear to have lost our Deputy Chair, but he will turn up, I'm sure. So I now welcome representatives of the Queensland Family and Child Commission to give evidence. For the Hansard record, would you please state your full name and capacity in which you appear before the committee?
Yes, thank you, Chair. I'm Luke Twyford. I'm Queensland's Family and Child Commissioner and also Chair of Queensland's Child Death Review Board.
Thank you, Chair. My name is Tammy Walker. I am the Director of Reviews and Child Death Prevention with the Queensland Family and Child Commission.
Thank you very much. Although you are not required to give evidence under oath, this hearing is a legal proceeding of the Parliament and has the same standing as proceedings of the House. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and does attract parliamentary privilege. I'll just do a quick run around about who we are. So I'm Louise Muller-Frost. I'm the member for Boothby, which is Adelaide's southern suburbs.
I'm Claire Clutterham, member for Stair, also in Adelaide, next door to Louise.
Mr Gregg.
Matthew Gregg, member for Deakin from the eastern suburbs of Melbourne.
And Mr Ng.
Gabriel Ng, member for Menzies, also from Melbourne's eastern suburbs.
Thank you. And our Deputy Chair is Mr Hawke. I can't remember what his... Do you remember? Mitchell? There we go, member for Mitchell. He'll arrive. Do you wish to make a brief opening statement before we proceed to discussion?
We each have a short one, Chair, if that's
Fantastic,
okay.
Thank you.
I wanted to start by acknowledging the traditional owners of the land we're meeting on and thank them and recognise their elders past, present and emerging. Often when people ask me what it is to be a Children's Commissioner, I have to stop myself from saying sometimes my bleakest truth, and that is that my job is too often requiring me to look into the depths of humanity in Australian society and look at the human tragedy that exists within our communities. Rates of domestic and family violence prevail throughout the entirety of my work. Over the last 5 years, I've reviewed the deaths of 2,000 Queensland children and conducted and led forensic studies into 350 of those children who were known to the child protection system the year before their death. In those cases that I review, domestic and family violence is in at least 73% of those children's lives, and the rates of suicide that I record in the Queensland Child Death Register is continuing to increase. When I commenced my role, adolescent suicide was the most prevalent form of death for teenagers aged 14 to 17. In the last 5 years, and in the last 2 years specifically, that has now stretched into earlier age brackets, and in Queensland, suicide is the leading form of preventable death for children over 10. I've also led forensic studies into the cause of suicide, youth suicide in particular, and Ms Walker will speak to that, as well as some detailed research into filicide, the act of parents killing their children, and in many of those cases, murder-suicide being the motivation. Our 2021 research into suicide really tried to convey that this should not be understood as a single act, that too many of our children and adults are living with complex lives, life with adversity that builds up slowly over time, that is seen and recognised by government services, that is acknowledged by neighbours and peers and friends. But there comes a point in people's lives where they take action on that build-up, that accumulation of life with adversity. I've recently made a submission to the second action plan, and I would like to send that to this committee when I return to my office. My overarching message within that and for you today is that our children have one life, and it is time for all levels of government to stop fragmenting those lives into separate portfolios, separate issues, separate incidents. We need to work holistically. True prevention is about holistically seeing the child and the family as they are. My underlying thesis is that it is not the role of government to control its citizens. We do not need more laws and more police officers to prevent domestic and family violence, sexual abuse or suicide. Control cannot be the answer. It will not get us to where we need to be. Rather, it is the role of governments to provide the scaffold and support so that our communities, our citizens and our children can be the best versions of themselves. I'll now hand to you, Tammy.
Thank you. Thank you, Chair and Committee, for inviting our evidence today. My name is Tammy Walker and I'm the Director of Reviews and Child Death Prevention with the Queensland Family and Child Commission. I oversee the operations of the Secretariat for Queensland's Child Death Review Board and the Child Death Register. In the reporting period of 2024 to 25, the Child Death Register recorded 24 child suicide deaths, up from 19 the previous year. Of those 24, household dysfunction was identified in 7 cases, with exposure to domestic violence the most common form present. 11 of the 24 cases had a documented history of alleged childhood abuse and neglect. Separately, in 2024 to 25, the Queensland Child Death Review Board considered the deaths of 64 children, including 5 suicides among young people aged 15 to 17. Since its inception, the board has reviewed 31 child deaths by suicide. Case reviews consistently indicate domestic and family violence is frequently present in the lives of children who die by suicide. This exposure, however, is not systematically or consistently recorded across service systems, and as a result, the contribution of family violence to suicide risk has not been able to be reliably monitored over time. Nationally, the Australian Child Maltreatment Study has found that 43.8% of young people aged 16 to 24 had experienced exposure to domestic violence during childhood, the most common form of child maltreatment measured in that study. Young people with maltreatment histories show stronger associations with suicide attempts than other adults. Suicide is rarely attributable to a single factor. Evidence shows it reflects cumulative harm, including trauma, family dysfunction, abuse and neglect, within which domestic and family violence is consistently present. Thank you for hearing our evidence today, and I welcome any questions.
Thank you both for those opening statements. They were very sobering statistics, and thank you both for the work that you do in a really tough environment. Can I start by asking just a little bit more about the process, about how your child death review, particularly in the context of suicide, works? Who decides which cases need to be reviewed? Where does the data come from? How do you have a legislative framework that requires giving of data? Is it public data, private data, NGO data? That real process piece, please.
Yes, thank you. And I'll try and do it in a short manner, and we can provide our procedure document to the committee if it helps. So under the Queensland Family and Child Commission Act of Queensland, I am responsible for the Child Death Register. The coroner and the police will provide a document to me to record the deaths of a child on that register, and from those documents we're able to glean statistical points that we can then analyse in the future. For a child within that data set that is known to the child protection system within the 12 months prior to their death, the Act has a separate part and requires the Child Death Review Board, an independent committee, to lead reviews of those deaths. So a notice will go from the coroner or attending police to the Department of Child Safety. They will confirm that there was contact in the 12 months prior, and that will trigger a series of notices to every human services government department who have a 6-month legislated timeframe to conduct their own review into how they served or serviced that family. So commonly Department of Health, Department of Education, Department of Housing, Department of Youth Justice, Police will provide reports to me following those triggers, as will the Department of Child Safety in every case, given that they are the antecedent to this process. My team then receive a plethora of agency reviews based on the child's life, or indeed the child's contact with government systems in Queensland. And we then take 6 months to review not only those reports, but to identify any non-government organisation or private provider who may have had a role to play in that family circumstances. And I have the power to issue information requests to non-government organisations. Mm-hmm. The compilation of all that work is then presented to the 12-member Child Death Review Board in Queensland, who analyse what my team has pulled together and presented as the thematic issues and concerns. They will discuss that, seek further information, and at the end of each year produce a Child Death Review Board annual report that is tabled in Parliament and includes the life timeframes of those children whose cases we've reviewed. important point I want to make is that process is focused on, within the legislation, it is set up to ensure that the government learns about the quality of its service delivery system. It's not a review focused on the cause of death, and it's enabling the board to look much more broadly at service systems. So we might lead reviews into, for the 70 cases that came to us last year, for example, hypothetically, we might decide that school non-attendance or school refusal was a really clear and emerging theme, and we're therefore able to conduct a thematic review into that issue, drawing on the lived experience of those lives that have been lost. So it's a policy system quality focused review process rather than a case-specific compliance, blame or individual causation review. It distinguishes us from the coroner's process, which can occur in a dual fashion for some of these children.
Thank you. Now, you mentioned the child death report, which is tabled. Is that, are your reviews actually published or public, or is it just the recommendations? So
in that report, each chapter will outline the reviews that have occurred. It will include case studies of the lives that have led to that review. So to that extent, they are public. The agency reports that come to the board to enable that work are not published, but they are made available to coroners' courts and to other courts when required.
Thank you. Now you've got a 12-month, like if the child's had contact with child protection in the previous 12 months. Is there a particular reason why that 12-month time period was?
Prior to my time, it was 3 years.
Right.
It changed to 12 months prior to my arrival in this role. There is a workload volume issue, and one of the key reasons we are moving more and more towards a thematic systemic review, looking at the multiple lives within a single review, is to try and make sure that we're honouring each child's life and not singly focusing on the top 5 that are the most likely to lead to learnings, but instead continuing to ensure we look at all. There's also a grim fact here that we're reviewing the same issues over and over again. For 5 years in every review report, we've had a chapter on domestic and family violence. We've made clear recommendations to government around what needs to change. The ability to stay motivated and continue to produce deep forensic reviews onto a very complex social issue and try and find solutions gets hard and draining. I'm still motivated to do that work, but we can constantly as a board discuss what is the impact and value of us reviewing this case, and how do we ensure that it translates to government action and community awareness. And so finding the balance between the two is really important, and we seek to make sure it's not simply our job to publish trauma, that surely our society needs more than headlines. It needs a call for change that leads to action.
Okay. Are there any particular recommendations that you'd like to bring to our attention?
Great question, all of them. We've done some significant work around high-risk behaviours in adolescents, often leading to transport deaths or suicide, and I would like to acknowledge that those two might cross over, and what might be recorded as a transport death may indeed be intent to take an own life. But I think what those reviews have called for is a deeper understanding across the child safety system, youth justice system, police system, and indeed the Australian community, that young people who are finding themselves out of school, out of home, living on the streets, are desperately in need of our love and care, not our prejudice and judgment. And for too many children, they are exiting detention centres and then taking their own lives. And so those recommendations call for a more compassionate understanding of what's happening earlier in these children's lives that would not only keep them safe, but would make the community safer.
Thank you. You've mentioned a couple of times schools and behaviour around schools, exiting schools. Are there other correlations that are worthy of us being aware of?
Sure. In 2023, the Commission led a review of 30 cases from Queensland Child Death Review Board to identify the common experiences for these children. And one of those was teenagers who did die by suicide. In the sample population that we reviewed, all of them were disengaged from school. Those who still had any connection with school, it was purely administrative. They were certainly not attending classes. They weren't engaging with their teachers, their peers, or the support services that school could provide through the secondary service system as well. So from that review, we also understood that there is a difference, of course, with the metropolitan versus regional, rural settings as well, where service delivery is interrupted, service delivery may be sporadic, and the further that you travel outside of major cities, the more disparate that connection to services is, and therefore then the ability to actually identify, intervene and respond to suicide risk as it's developing for these young people is much more difficult.
Thank you. I might like it there, Mr. Hall.
Yeah, no, thank you, Chair. Thank you for your submission. I just want to ask a few basic questions. I've got a couple more detailed questions about information sharing and some of your thinking in relation to this. We've heard evidence from a lot of agencies around the country. Just so you are specifically an independent statutory authority, aren't you? Independent of government?
Yes.
So you
correct.
provide advice to government or to ministers regularly about this kind of matter? Or?
Correct.
Yeah, okay. That's good to understand. So in relation to this, I mean, you've got a very important body of work and an important remit. Do you, what would you say about the Queensland laws? I mean, I understand there'd be a Queensland Privacy Act and Queensland that inhibit the data sharing or otherwise from private providers and people who have access to data. And have you ever made any recommendations to improve, to government of any persuasion, to improve those laws so that better data sharing could occur in relation to Queensland, your jurisdiction?
Thank you for that question. I feel like I could talk to that for the next 2 days and
Please,
not cover all my thoughts. I've certainly... last year I led a very significant review into child sexual abuse in Queensland and spoke to the data gaps across government and private providers and how people who seek to harm children exploit those gaps and indeed avoid surveillance because of those gaps, and recommended that Queensland create a proactive intelligence hub to detect threats to our children. I recognise that slightly...
Could you just explain it for a moment? Just what's an intelligence hub, just in this context?
So in very short form, the review found that the offending of Ashley Paul Griffith could have been detected far earlier than it was, that there were 18 missed opportunities.
With data matching in a central...
And if a regulator knew that police had a prior report and that there had been 3 private concerns raised within an early childcare centre that never went to a regulator, as soon as you can put all that intelligence together, you can see the threat. I think that's slightly different to how we need to respond to domestic and family violence and youth suicide or suicide. But it does make the same point. We are treating individuals transactionally across all our government portfolios and community services. People working with a family will know what they know and will either be aware or unaware that there are other case managers also working with that family. Recent reviews we have done have shown a family of 4 with 23 case managers across NGOs and government departments. I would be willing to stake a vast sum of my own money that they don't all know what each other are doing. They haven't seen each other's most recent status reports, referrals, and we have a disconnected patchwork trying to support our most vulnerable families. When I talk to information sharing and intelligence sharing, I think we get stuck, particularly in the legal fraternity, of which I am a member, trying to tease this out as empowering one person on the front line to send another person on the front line a piece of information. and we see it as a transactional exchange of paperwork from one to the other, where our large organisations and our busy lives could do that far more efficiently for children and families if we integrated our software. The extent to which a child living in residential care who is self-placing has a child safety officer, a former foster carer, 3 youth workers, contact with 6 different police officers within a week, is being phone rung by their youth justice community officer. All of that, if it's sat together, would help us serve and meet the needs of that young person far better. So I speak to information exchange as the next evolution of information sharing. It's not enough to just share. We need to be able to access the information we need to help the person in front of us. And I think we've all, across the Western society, got a long way to go on that, and that's going to require rebalancing privacy protections with child protection. And we speak about children being precious and children need to be safeguarded, but we don't reflect that in the privacy constraints around how someone working with that child can actually see what's going on for that child.
You know, I think that's important evidence, and I agree about the privacy issues. I think they need modernising, absolutely. You're arguing for a whole community benefit, not just an individual's privacy, but a greater impact of certain privacy laws or the operation of them. Just on that though, even when we get to a very sad situation, we've got all these terrible things that you're speaking of, but when we get to a very sad situation where a child is suicided or we still have privacy in the way of information once a child is deceased. It's, you know, why is this? I mean,
I think to the why, I think there's still, and probably rightly so, there's a level of stigma and concern about the well-being of others in amongst this process. As part of the Child Death Register, I do operate a child suicide notification service. So if a child enrolled in a public school is found to have died by suicide and my staff receive that record, we're able to send an alert to that public school and have the Department of Education put in place counselling and other support services. We've tried for the last 4 years while I've been in the role to navigate how we could do that for independent and Catholic schools, but the privacy concerns override it because there's no central Department of Education place to send that alert to, and instead I would have to send it to every school. And so there's always this balancing of public good, individual privacy, and the do no harm principle that I think we don't step through carefully enough, either in overprotecting privacy or not understanding the harm we may be doing.
Yeah, so I get the evidence about privacy, we all do. You're a lawyer as well, as I understand your evidence, yep. So, but why has this distinction, repeatedly now it's coming up, and you've just raised another example about the public system for schooling and the private. I mean, the life of a child in either system is of equal value regardless of anybody. So why has this distinction continued to be a problem with private? And, you know, let's be frank, most Catholic and independent still get government, you know, enormous amounts of government funding, state and federal. What's the at-law problem that we can't get around, that we can hear about the lives of public students, but we can't hear about, you know, the very significant impacts on society of suicide in the...
So it's not who we can hear about. Obviously, I report on all suicide deaths.
Well, you said you can't be told about it or something.
I can only notify the public schools.
Why is that?
And so my answer to your question is it's the mechanics, it's not the law. I can mechanically, because the Department of Education in Queensland knows all the public school students, we can therefore identify which school needs to be notified.
Sorry to interrupt, but this is very important. You're saying the Catholic system doesn't have a central office where things get reported. I'm surely they do. They have diocese offices, they run, 30, 40 schools. I mean, are you saying there's no notification protocols inside these systems, or what are you getting at?
There is no joint register of students enrolled.
Right.
So if I was to say...
but have you asked them,
yes.
Without prejudice, have you asked these systems for this information?
Yes, absolutely.
And what's their answer to you?
We've been working on how to resolve this mechanical constraint for the last 3 years.
Yes. How long's that been going on?
3 years.
And have they've said not no, they've said we're trying to help you with this?
Yes.
And you're still ongoing about this?
That's correct.
Okay. And how would you describe the progress on that?
Vexed. It's a vexed issue. If there was a central register of all students so that we could identify which school needs the notification, that would be the easy way to resolve this. I'd also say that home education and children disengaged from any schooling is another critical issue. We don't know who's not enrolled in school. There is likely up to 1 million children that were once enrolled in Queensland schools that we or the system does not know where they are. It's likely they've moved across the border and enrolled in a new school. They may be enrolled or not enrolled in home education that their parents are leading, or they may no longer be present in Queensland. So that's the sort of technical, mechanical issues that we come across as we try to resolve
and
how to safeguard children.
And is there a process with your statutory authority to, you have one to try and make progress on these issues, but that's not joined up with other states, that's just your Queensland work?
Correct.
Yeah, okay, I'm getting the picture. So federally though, do you cooperate? Are there any other state agencies you cooperate with on this kind of work, or in other states I'm talking about? Yeah.
So all Australian New Zealand Children's Commissioners meet regularly. Yeah. We've all got slightly different functions. Not all of them run child death review processes. So I would say where we can, we work across borders, but the joys of federalism is that everything's slightly different. It sounds the same, but it's not quite. And so where we can learn and support each other, we do. But each state is very unique.
Okay, but even if you're not asking, I mean, you are, but you're not asking at this occasion to get the enrolment details of all schools. They can't even notify you about their data at the moment, is what you're saying. And no one's getting notified about that data, as far as you're aware.
Enrolment data, no, certainly.
No,
that's right.
I mean actual suicide data or other data that,
So I'm confident I receive notification of every suicide.
Yep.
That does not have a field on any of the notification around do they attend school and what school.
Right.
So I am left with a name and a date of birth, and the only thing I can check is the Department of Education's public school enrolment fields. I can't test against any other fields.
Right. Now that's very important. Now I have a full understanding of that. Thank you. That's very helpful.
Thanks, Chair. Just want to start by saying thanks both for your work and your very powerful opening statements this morning. Mr. Twyford, I was really interested in your perspective, which is unlike any other witness I've heard, and that's in the sense that you told us control is not the answer. We don't need more police, rules, laws, what have you. I think almost every other witness who's touched upon that has indicated there's a lack of policing, a lack of frontline services, a lack of funding. So I was hoping to unpack that a little bit more. Are you sort of saying there are adequate resources in place, they're just not being used effectively? And sort of in answering that, can you talk about, you said the role of government was the scaffolding and support. Put all that together, what does good look like, I guess? And I think, sometimes in this inquiry, I think, gosh, we just have to scrap everything and start again and reinvent the wheel, because this is a giant crisis facing our nation. But my sense from you is that there are some green shoots there that need to be, given a bit of TLC in the right way, and we could make some progress. Just over to you.
Thank you. I would certainly welcome more resources into any of our statutory systems and tertiary systems, be it child protection, youth justice, domestic and family violence, policing, housing, mental health, education. But if we are in an era of polycrises where everything is a crisis and there is insufficient resources to meet demand, I think we need to recognise that more and more resources might not be possible. So that's my first point. The second point is, in all the cases I review, of course, with more resources at the tertiary end, we may have saved it just in the nick of time. But overwhelmingly, if you go 12 months earlier or 24 months earlier, a slightly less costly investment in prevention and support would have made the world of difference. For that family of 4 with 23 case managers, I suspect they would get a better service from just one good case manager rather than 23 that the taxpayer is funding. So my question is not at all saying that we've spent enough and please don't spend any more. I would hate people to think that's what I'm saying. Yeah. My point is that governments need to find a way to help the community prevent domestic and family violence, to prevent suicide, to prevent adolescent mental ill health, to prevent the increase in illicit drug use. And I see that as a task for the whole community, not just government, and that perhaps distinguishes me from other people that have occupied my role. But I truly believe that the role of government must be to help the parents and the neighbours to understand what the journey of adolescence is, how it can go wrong and what they can do to support it turn right again. To constantly think that a police officer can be the only one to call out the behaviour of a man that is abusing his wife or a child doesn't do enough for our society to address these high rates that we see. We have to all lean in and play a role, and that requires us to know what to do, how to do it, when to do it. And so I do see a bigger need for all levels of government to do community awareness raising and community capacity building. My recommendations about child sexual abuse in that regard are very clear, and I am waiting on the federal government's response to those 10 recommendations in plain sight. But it's about community uplift in my mind. The rates of domestic and family violence, the rates of suicide and the rates of child sexual abuse need to be prevented, not responded to.
Mm-hmm. Yeah, okay, that's a very helpful answer, given me a lot to think about. And the other thing I thought when you first started speaking was just like, what is going on? Like, what is going on in our country? And we're not even, across the Indo-Pacific region, we're doing better than, our neighbours. Like, what is going on in our country that family domestic sexual violence and the impact on children and women in particular, although men are not immune as victims, has reached this crisis level? Like, is it human nature and we're just never going to be able to stamp it out? What is happening?
Well, I hope not.
What do you see? What do you see?
Certainly I keep performing my functions because I believe things do change. Yeah. We've seen great reforms and announcements over the last 5 years in my role. People are more aware of things like child sexual abuse and online harm, and there are laws and policies and programs being put in place to make a difference. So I think we know what we need to. We know what the problem is. We're not quite sure and unified on what the solutions are, and that's the constant public debate and political debate that we're having in Australia. We're not quite sure on whether national consistency is the main aim or allowing states and jurisdictions to pilot and progress in their own way to learn what best practice might look like. And I don't think, and I say this clearly and in plain sight, I don't think there's a central point of leadership for children or families. We have a national cabinet with a page-long list of national priorities, and the word child isn't on there once. And I think when I listen to political leaders at every level and of all forms and varieties, children are one of our most precious resources, but they're not acknowledged as a national cabinet priority. The childhood policy and parenting and family policy is spread across multiple portfolios. The strong work I have been part of on child sexual abuse in early childcare has involved at least 6 federal ministers and multiple state ministers, attorney generals, all playing a role, but a very decentralised approach to child sexual abuse as a primary issue. And so we start to talk about communications and online environment regulation. We talk about early childcare regulation, and very soon we see great gaps, and then Border Force plays its role and the Australian Federal Police plays its role. But who's the conductor of the choir? And so I think I've shifted your question from what's gone wrong to perhaps hopefully what can go right or what more could be done.
I like that perspective.
But I do agree there are days where I go home and am drained from the humanity that I read about in the files. But I'm surrounded by a family and neighbours and friends that demonstrate love and care. And maybe that's the simplest solution for all of us, is just to show a bit more love and care.
Community. Yeah, thank you. Thanks, Chair.
Thank you, Chair, and thank you, Mr. Twyford and Walker, for the important work you do, and also for sharing your expertise today. I suppose just to go into a little bit more detail about some programs that you might have seen that are addressing things in that holistic way that you said was really important, or that are doing that community capacity building. Are there particular examples that you'd point to that you'd suggest that we could have a look at that might serve as a good model?
Excellent question. I'm just wondering if I might take that on notice to make sure I give you a very clear response. If I named a few people today, I worry I would not be giving you the full context. An example of a community rising up, as some of you, or all of you may be aware, we do have a housing pressure in Queensland. We have an increasing number of families living in cars. There's a local school I'm aware of on the sunny coast who knew that their students and parents were living in cars in the car park near the school. And the PNC did a fundraiser and opened a laundry on the school grounds. So it's not a solution to housing, and it's not the Department of Housing providing a solution, but it's a community recognising need and responding to need. And then the next step from that is at that school-based laundry, now Department of Housing and other support providers can be there to offer counselling and support in a community-based way. So I guess that's what I'm speaking to, is the boundary between a formal government-funded program and what's happening in our community, and how do we make those two things meet.
Thank you, and we would appreciate, I suppose, some more of those examples on notice, as you've said. My other question was just around where we've had a number of community organisations say it's really important to have youth-specific services because often young people are not treated as victim survivors in their own right and can be completely ignored in service provisions. I was just wondering if you would agree with that, and if you could talk to whether or not you also consider it important for there to be youth-specific community services in the ecosystem.
Yes, I agree with that, and I agree there does need to be youth-specific services. The submission I've just made to the next National Action Plan goes to that in great detail, and I tend to send that to you. Young people are experiencing a completely different childhood to the one we did. The world has moved incredibly fast. We're also far more aware about the impacts of stress on young minds, and stress and fear are the predominant features of a house that lives with fear of violence and actual violence. I do want to give a call out to young Ruby, a Queenslander who, with her lived experience, has built a webpage called Kids of Purple. It's a referral service, an information service for children impacted by domestic violence, written by children who have had that experience. And she did that, as she speaks publicly about, because searching for support on her phone in a home led her to adults-only services and call centres that wouldn't take a call from a child. And so I think that as a case study speaks to us all needing to speak to children about their current experience, to understand how they see it. The Victorian Children's Commissioner and other non-government organisations from Victoria produced an excellent video about young people impacted by DVOs and living in homes where the police officers would only respond to the adults and wouldn't understand both how the teenage boy was a protective factor for his mother, but also a victim of the things that were happening. And so to be relied upon but also not seen. and this double-edged sword. So I completely concur. We need to not only see and understand the young people in the system, we need to hear from them and empower them to create solutions.
Thank you. And my final question is around young people who might become perpetrators of family violence themselves. And it's probably not something that we've touched on so much, but do you have any observations on, I suppose, the recognition of that problem and what kind of supports might be available or should be available?
Young people that experience violence, trauma and abuse are at a higher risk of many profound lifelong impacts, including mental ill health, substance misuse, suicidality, self-harm, and unfortunately repeating cycles of violence. That is not to say that all victims will be part of that cycle, and I think we often worry about labelling people or predictively labelling people that we don't speak about it, but we need to. And if we are going to break the cycle and do true prevention, then it's all about identifying who needs earlier support. In plain sight, the review I did into child sexual abuse, I did speak to the lack of funding for harmful sexual behaviours amongst adolescents and children, and how with greater intervention we can prevent people escalating into child sexual abuse and child sexual abuse offending. And so it's a really niche role that is very hard to talk about, where there's not many votes to be won in funding perpetrator prevention and perpetrator intervention services. But it's absolutely critical if we're going to turn the tide on the prevalence rates that we see. Working with the people who are or have been or are about to become offenders is the clearest way to prevent.
Thank you. Thank you for your evidence, Ken.
Thank you.
Thank you. Now, I can see that our next witness is online, so if I can just let you know we're running about 10 minutes late, and thank you for your patience. Mr Gregg.
Thank you, Chair. I'll try and keep my line of questioning brief. I was just wondering, how do we ensure concepts like cumulative harm and coercive control remain empirically measurable and falsifiable, rather than just kind of a label we can stick onto any adverse outcome? Because we've heard a lot of different definitions of these terms and being applied differently. Where is the role for just creating clarity on these matters?
I feel like every question I've been asked today is a whole round table in amongst itself, and there's no way to answer that in a short way. The distinction between laws and rules and policies and programs and then practice, I think, deeply matters in this space. So often we're discussing what the rules should be when actually it's what the practice should be. So how do our police practice law enforcement in a way that recognises coercive control? How do child safety officers recognise cumulative harm and the impacts of adverse trauma? To my mind, and the cases I review, all depends on the quality of practice, not the quality of the rules or the definitions. So it comes to setting the framework, dropping it into policy and program and funding requirements, and then training the staff in what they need to do. It's a very important area. It's one that we too often see as something we can't measure holistically across the system, but it is evidently evident every time we build a life timeline for a child that comes before the Child Death Review Board. You can see the gap where schooling stopped. You can see the multiple placements where they moved houses. You can see the 200 top charges they have with the youth justice system and policing, and you just see life adversity escalate and then the death event occur. The problem is you see it in retrospect when you've got the time to see it. When you're the police officer there at the home, what can you see and how do you record it? That's the need for high quality practice, and that's a forever job.
I guess kind of linked to that, in the world of clarity, I've noticed, and I'm sure you have as well, that the behaviours of younger people have changed in terms of relationships. We've now got like a normalisation of tracking apps, for example, in intimate relationships, which many older people would consider a gross invasion of privacy. Are we good enough at teaching where the lines are? What is acceptable, what is not acceptable? We have a lot of respectful relationships training and things like that, but is there still too much ambiguity as to where the lines are?
Yes, and we're also really bad at listening to the children about where they think the line should be. So this has to be a modern conversation. The young people using technology and apps are creating their own rules for themselves as a cohort or as subgroups or as individuals. And us as adults who haven't even heard of this technology are trying to set rules that we can't quite apply to their lives. So I completely agree with you. We need far more depth to our discussion and understanding, but we must include the young people in what does a respectful relationship look like in 2030, and how is that different from a respectful relationship in 1980, and what are all the different elements to that, all based on the same common principles or the same common values. And I think we're not doing that very well. We're trying to apply 1980s thinking to a modern world.
My last question, given the time, we invest a lot in, I suppose, identifying risk factors and responding to them. Are we investing adequately in protective factors that increase resilience and the ability of someone to hopefully either avoid or be in a position to respond healthily to a situation?
We are investing in protective factors through our formal government portfolios, but we've completely lost sight that the single best protective factor for a child is their parent. And are we actually helping parents to parent in the modern world? Have we given parents the tools they need? And over the last 30 years, we know children are spending less and less times within physical proximity to their parents. So what does it mean to parent from a distance? What does it mean to parent online? That's where some more efforts around safeguarding is desperately needed in my mind.
Thank you very much. I think we could discuss these topics all day.
I'd welcome that, but I won't.
Thank you.
Thank you very much. Thank you for your attendance today. So you'll be sent a copy of the transcript of your evidence to assist you with answering questions taken on notice today, and you'll have an opportunity to request corrections to transcription errors. Once you've received the transcript, you're asked to provide responses to any questions on notice within 2 weeks. Please forward these and any additional information that has been requested to the Secretariat. And if I can just add on, Ms Walker, you mentioned a 2023 report, and I didn't write the name of it, but it was all of the children were disengaged from school. That report will be useful as well. Thank you.
Of course. Thank you.
The Secretariat will confirm these arrangements when distributing the transcript. Please note that responses to questions on notice will be published on the committee's website as submissions to the inquiry. And if there's anything else you think that you'd like to add, please feel free. Thank you so much for coming along. That was really, really useful, and thank you for your really tough work.
It. Thank you.
Thank you. Right. I think it's Turner. Is that what you're saying, Ms Turner? Sorry? Maybe? No, none of us can read
Definitely
that far.
Sharon.
Yes. So is our next witness still online? I think it's Sharon Turner.
Yes, it's Sharon Tanner.
Tanner, sorry. You're
okay.
on a small screen at the end, and we couldn't quite see what the second word was. Thank you so much, and thank you for your patience. So I now welcome representatives of the Domestic Abuse Resource and Training Institute to give evidence. For the Hansard record, would you please state your full name and the capacity in which you appear before the committee?
Yes, so Sharon Tanner from Domestic Abuse Resource and Training Institute Australia as the Chief Operating Officer.
Thank you very much. Although you're not required to give evidence under oath, this hearing is a legal proceeding of the Parliament and it has the same standing as proceedings of the House. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I'll do a quick whip around of who's on the committee. I'm Louise Muller-Frost. I am the member for Boothby, which is in Adelaide's southern suburbs.
Alex Hawke, the Deputy Chair, and from New South Wales.
Claire Clutterham, member from Sturt in Adelaide, South Australia.
Mr Ng.
Gabriel Ng, the member for Menzies in Melbourne's East.
And Mr Gregg.
Matthew Gregg, the member for Deakin, also in Melbourne's East.
And we may be joined by others. People pop in and out. So, Ms Tanner, do you wish to make a brief opening statement before we proceed to discussion?
Yes, I just want to say thank you for the invitation, the opportunity to present today. Our CEO, unfortunately, was unable to attend as she's delivering training. So if there's anything certainly that I can't answer, I will take a note and we can provide that in written format.
Yeah. Lovely. Thank you very much. Can you talk to us, just briefly give a little bit of an understanding of the role of DART and what your main functions are?
Yes, so DART Institute is a registered harm prevention charity. We were founded in 2022 that builds workforce capability across the DV and sexual violence sector through our specialist training, reflective practice and clinical supervision. DART supports professionals across police, justice, child protection, health, mental health, AOD, so anything that intersects with family and domestic violence, workplaces and specialist DV services to recognise and respond to coercive control, psychological abuse, social entrapment and associated suicide risk. Our role is to translate evidence, research, specialist practice into training, education that professionals then can apply consistently and confidently within Australia's system, so improving that professional judgment and the safety of the decisions that practitioners make. Since we were founded, we have worked with hundreds of organisations across Australia, and we've delivered training to just over 4,000 frontline practitioners. We are also the delivery partner for the Attorney General's Department to deliver training to 10,000 police officers nationally throughout this next year as well.
Terrific. Thank you very much. We've heard a lot about coercive control and also the notion of entrapment, but we're also hearing that the understanding of what it is, what it means, what it looks like is very variable across the sectors. Is that your experience of that, and are there particular areas that you think are most misunderstood? Yeah,
so depending on where organisations sit in the broader system response to family and domestic violence, they can have different ways that they identify, screen family and domestic violence based on their own organisational lens or their own legislative requirements as well. So there can be that inconsistencies to documentation and training and how they are assessing risk. That is correct. And sorry, what was your other question that you had, sorry?
What are the particular aspects of coercive control that you think are most misunderstood or not recognised?
Well, definitely, if we're looking at suicide here, we would say that is something that is still probably recognised as an individual choice. So it's not kind of identified it's understood as an individual mental health issue far more often than it's understood as a consequence of coercive control, the psychological abuse and social entrapment. So, victim survivors would frequently present with that hopelessness, exhaustion, suicidal ideation following prolonged exposure to coercive control, where physical violence is absent. So these presentations are not always recognised as indicators in domestic, family and sexual violence. And so that opportunity for that earlier identification and intervention is lost. So we would say that improving that workforce capability to recognise coercive control, the psychological abuse and the social entrapment that I mentioned allows practitioners to identify suicide risk earlier and complete more informed documentation, risk assessment, and make those decisions that prioritise victim survivor safety.
Thank you. Yeah, but look, we did hear earlier on from somebody who said very much the same as what you've just said there, that often practitioners are dealing with people in terms of, you know, a mental health diagnosis rather than that context and dealing with the precipitating factors. And part of that was also looking at the risk assessment and how a tick box of risk assessment was somewhat inadequate as opposed to perhaps a narrative version. Can I ask you how you train people around that risk assessment and that recognition of what sits behind a diagnosis or sits behind somebody's situation?
So we, depending on what state we're in or training, we'll come back to that state's risk assessment. So, you know, Melbourne, it's the Marin, here it's the CRAF. So we'd be kind of looking back to the national competencies, we'd be looking to work with those risk assessments. But certainly it's, it's not always something that is actually on those risk assessments in terms of what is being captured. So we would be looking to, looking at the touch points of where victim survivors are also coming into the system. So, you know, GPs would be a big one in terms of then linking back, as we said, around mental health and having that screening and identification to be looked at to have that incorporated into it as well.
If you're working across all of the different states, do you have a sense of a best practice in any of the states? Or, I mean, you're welcome to take that on notice if you don't want to name and shame.
Look, we really do refer a lot back to the MARAM. The MARAM is incredibly thorough. It's comprehensive in the state of Victoria. The one here in WA is certainly being looked at and being changed at the moment. So, yeah, I would say that the state of Victoria actually certainly has a really good one that we refer back to a lot in terms of that risk assessment.
Lovely. Thank you very much. Mr. Hawke.
Yeah, look, I've got a question. So in relation to coercive control, just obviously you're monitoring all the developments. You're WA-based, as I understand, right? You're sort of...
That's correct,
but
yes.
you have a national remit. You can look around Australia, obviously, in relation to coercive control.
Yes.
So with the New South Wales legislation, you're familiar with it, obviously, it's come on in relation to coercive control. Would you speak to how are we progressing in relation to coercive control being legislated in for other jurisdictions?
So the state of WA, we're actually having those conversations at the moment and doing a lot of, I guess, conversations around how it can be captured, what that would look like in the context of how it would work here. So having a lot of consultation groups. But yeah, that's something that is still ongoing. We know that there are other states that have actually legislated that, but there are some states that haven't as yet.
So, yeah, so that's a good update. How does the New South Wales legislation doesn't meet your, what would your comments be about how it is effective in increasing the data available and the work that you're doing? I mean, are you already seeing early signs? Because it's only been implemented for, about 12 months, is it now? I understand something similar, or it's quite recent, the coercive control legislation?
Yeah, so can you just say that again? Ask that question again.
Yeah, so the first part I was saying was...
in terms of training capabilities? Or?
Yeah, so, I mean, given that we're getting more understanding of coercive control, it's been legislated within a major jurisdiction, it's in operation. You're obviously monitoring the impact of that legislation, and therefore, what are the early signs in relation to how it is effective against your benchmarks that you've raised today and in your submission?
Yeah, so without actually the trainings, without that workforce capability to actually understand coercive control, then we won't actually see that translated into practitioners understanding how to document coercive control if they don't understand it. So that is a big area that we've actually been working on at the moment with a number of organisations, is how they actually understand, recognise coercive control in the context of family and domestic violence. So that workforce capability for us is a really big prevention strategy in its own right, so that every practitioner can understand and recognise coercive control. And as I mentioned before, around the social entrapment, understand relationships with suicide risk is better placed to intervene earlier and more safely. So for us, we're seeing that confidence in practitioners being able to understand and map coercive control once they've actually had the training. So coming back to that workforce capability and investment in that is a really big piece for us.
Look, that's very helpful. I get your points on that. I want to understand something specific about this, because I think what you've said is very important. And my question is this: when you have legislation, as you know, you had the pre-legislation phase, the discussions, the implementation. Now we've got implementation in a major state. I understand your points about workforce and training. My question is, once that law is implemented, surely the driving, have you noticed in New South Wales, every organisation needs to get across the law because it's the law. Everybody has to take advice. Surely that's driving the outcomes that you're seeking in a major jurisdiction just by being the virtue of the fact that the law has been changed and the Parliament's made a law. How would you assess that so far? I understand it's early days in the legislative terms, but that's my exact question.
Yeah, I might come back to you on that one with our trainers who are actually on the front line, and certainly we can provide a written answer for that one too. Yes,
I'd be very interested, because that's really the argument. I don't want to say chicken and egg, but it's kind of like, once something is the law, everybody has an obligation to meet the law. Therefore, people have to get better trained and they have to understand the law and they have to train their people to implement the law correctly. So I'm just wondering how that effect works.
Yeah, and it also depends on each state's family court as well, because sometimes that is what we find is probably the hardest thing in terms of the law and the people who work within the court system also understanding that. And then the documentation that they receive is only as good as the practitioner who's actually writing that documentation that informs what the court are looking at as well.
Okay, no, thank you. They're my questions for now. Thanks.
Thanks, Chair. Thanks very much, Ms Tanner. I just was interested in training in corporate workplaces and just what that looks like. And then after the training has taken place, what is the sort of desired approach for corporate workplaces to take? Do they take it? And are you able to measure the success or not of that?
Yeah, so for workplaces at the moment, we're seeing quite a big demand coming through, where some workplaces are looking to, with the legislation that has changed just around, say, family and domestic violence leave that victim survivors are able to take, is they're looking at upskilling their HR and their leadership teams. Also, should there be staff within their team or workforce to actually understand and respond to victim survivors. So there has been a huge amount that we've certainly done in corporates or corporates inquiring with us that are also taking that trauma-informed lens as well, and then also wanting to understand how then they work with anyone who might be using violence within the workplace and how they can provide that wraparound support. And also, say, for example, large corporations where they have contact officers who might be working, say, if it might be Water Corporation, for example, they also want to be what we call family and domestic violence informed. So we have seen a great amount of, I guess, the government's campaigns around family and domestic violence of workplaces wanting to get into, on the back of that, but also due to legislation as well. How do we kind of measure that? We have ongoing clients who come back to us to say that their staff now feel more confident to respond and recognise family and domestic violence, but also support victim survivors in the workplace. And then they actually have ongoing training with us. So we might identify gaps within the workplace when we're there. We help support the policies and procedures that inform the work that they do. And certainly they come back to us just like we actually want to do more training. And then we also tailor training to those workplaces based on what they might identify within their workplace to help their staff.
Yeah, okay. And do you see workplaces approaching you in you know, for this sort of training, because of the psychosocial hazards legislation, I mean, it's a few years old now. I think it was Christmas Eve 2023 from memory is when these new regulations came in, and putting a positive duty on employers to take all reasonably practicable steps to minimise and eliminate psychosocial hazards. Is that a part of that, or is this seen in corporate workplaces something that happens at home and they just kind of need to be aware of it?
I would say that yes, in terms of that legislation that you mentioned, what changed, it has driven a lot of that as well. But I would say just in terms of that broader conversations now that we're seeing around family and domestic violence, a lot of workplaces are wanting to have that support and looking to have, I guess, that social causes and aligning back to things in the community where they actually want to be part of that conversation, which we haven't actually seen in a long time that I've been working in the DV sector before, that workplaces generally want to have, how do we support, how do we respond to victim survivors? How do we also support anyone who might be using violence as well? And having that bystander conversations as well. We even have football clubs coming to us saying, how do we understand bias, unconscious bias? So we're seeing not just corporate workplaces, but sports and clubs and community groups coming to us, wanting to have that leadership training and that coaching around DV as well.
Okay, that's a green shoot bit of evidence. That's good. Thank you. Thanks, Chair.
Thank you. Mr. Gregg.
Thank you, Chair. I was wondering, when it comes to measuring the success of the courses, I know it's quite common in adult education to measure it with reference to the confidence of participants, but do we have any empirical evidence demonstrating that this kind of training actually produces better outcomes for victim survivors?
Yeah, certainly. We can share some of our training surveys with you and just de-identify any information in there if you like.
Yeah, that'd be good.
Sorry, if I could just mention one thing about our training is that we work on a national level. When we started it, we wanted to address the gaps in the service system response. So our training not only is nationally aligned back to competencies, we have that accredited training, but it also is aligned back to the risk frameworks, it's evidence-based, because there is a lot of training out there. But what we're hearing on the ground is it's not necessarily aligned back to any minimum standards or national competencies and evidence-based as well. So when we look at our data, we can really see the change in people say if they came to our working with violence, people who use violence training, their confidence was really low before, and then we look at it afterwards, and it's increased significantly in their ability to engage with people who use violence.
Do we have any kind of, as a next step, data that goes beyond the confidence of the worker to ensure that that confidence is translated into better outcomes for participants? Also for victim survivors, because you can have confidence and not be any better.
Yeah, so we have done some case studies in the past where we've actually worked with organisations, say like a Women's Refuge, to look at their documentation and then the differences in terms of the outcomes, say, for women who were in the refuge as well. So there's certainly been case studies done with particular organisations, all our follow through to say we worked with an Aboriginal Health Service where we went back to them, we took those, those deeper dives with them to say, well, how's this actually changed the way that people respond to women coming into the medical service? And there was and that's something we can also share with you was the outcomes from that training as well, and what that meant to women and children entering that health service.
That would be great. So you mentioned national competency standards. Last I looked, and this was a while ago, the training had, I think, one kind of standard course that was made in Victoria, which did kind of cover the key ground. Is there an accredited, like nationally accredited course through, like, you know, as in on training.gov.au as an accredited package, or is this something that's been brought together elsewhere? Like, where are the national competencies, in other words?
Yeah, so we can certainly provide that information to you if you like, to show you how we align all of our training and what it's aligned back to, if that would be helpful.
Yeah, no, I was just, is it a national competency that all training providers, use, or is it something unique to your organisation?
No, it's just whatever the national competencies are, aligning it back to the National Action Plan as well. So any state risk frameworks, we align everything back to that, and territory aligned to. Yeah.
Okay.
But yeah, I guess, sorry, my point was not all training providers are actually doing that. So there's they're not meeting those minimum standards or those risk frameworks or, of what's out there, which is where it can become quite harmful and destructive. We call it DV destructive if the training doesn't meet that certain minimum standard.
Mm. Is there anything that kind of shocks kind of train? Is it like a particular knowledge gap that is surprising your organisation when you've come across it?
Yeah, I mean, I've sat in training for about 8 years now, and certainly, it's no wrongdoing of the practitioners who are doing the training. It's just that you only know what you know, right? And sometimes the biggest barrier for organisations to engage in training is budget. So it's not always made a priority within organisations. And so sometimes they realise actually that they're writing a lot of DV destructive case notes, say, around the woman who might be within their services. And then, of course, all of that gets subpoenaed, can go to court cases, and it can actually go against really the victim survivors within a family court. So sometimes when we work with, say, people around documentation, they realise actually they were writing DV destructive case notes, which then get subpoenaed, as I mentioned, and so we teach them how to partner with DV survivors, look at all the strengths. And also, even if they're not working directly with someone who uses violence, how they can still map that pattern of behaviour, which again, when they are subpoenaed those case notes, you're looking at really incredible family and domestic violence informed practice documentation.
So is in a way that it, viewing it or its exposure doesn't exacerbate the situation, or in a way that's kind of subtle that doesn't give the game away? Like what does that kind of informed documentation look like?
Yeah, so it's actually bringing visibility to the behaviours. So it's mapping out the coercive control, how that might be impacting the family functioning, how it's been used as a parenting choice. We're then probably looking at the victim survivor, all the strengths that they're doing to protect the children, how they might still be taking the kids to school every day despite the abusive behaviours, and providing that, still trying to provide that nurturing and caring, the safety planning that they're doing every day. So they are actually, what we find, and certainly when we've worked with family court staff before and family lawyers, is that can make a big difference when they are appearing in court, having that family and domestic violence informed documentation, because it's not kind of then looking at what the survivor isn't doing, it's bringing visibility to the harm and the pattern of behaviour.
Mm. No, that's very interesting. Another topic that we can go through for hours, but I know we don't have time, so thank you very much.
That's okay, thank you.
Thank you. Mr. Ng.
Thank you, Chair. I had a bit of trouble hearing you, but I think you might be throwing to me.
You're
and
fine.
Thank you, Ms. Tanner, for taking the time to speak with us today. It sounds like you're working with a number of organisations, particularly businesses, and you mentioned football clubs and sporting clubs that maybe we haven't heard from so much in this inquiry. What do you see their role is in terms of addressing coercive control and family violence and suicide, and what opportunities does working with them provide?
Yeah, look, I think for us is that whole assistance approach that's making safer homes, schools, communities, and without having, say, the football clubs or any supporting organisations involved, we're not having that primary and early intervention, because I think they play a really important role as role models as well, in terms of breaking down a lot of biases, which is what we've been working with a couple of clubs here at the moment. They wanted to go, well, what is unconscious bias? What does that look like in terms of our on the field and working together? So, but they've actually do a lot of leadership talks with us where we call them like a lunch and learn session, where we go in and we talk about gender drivers, social norms. We're unpacking a lot of things. We tailor it to them and to the football club. So yeah, absolutely. Most of the time, sometimes we're always preaching to the converted. So we want to have football clubs. We want to have the community organisations involved, because that's how we are kind of really working together to understand and recognise family and domestic violence and having those conversations with everyone. So, yeah, they certainly play an important role.
And on that preach to be converted, as you say, I mean, they can play a great role, and I mean, I know some organisations that are very receptive to this sort of thing. If you reach out to organisations, does it ever occur that are you able to assess whether or not it's only a small number of organisations, typically workplaces and sporting clubs, that are interested in speaking with their members about a really difficult topic, or is that something which, more broadly you've found that they're receptive to?
Yeah, absolutely. We've certainly found that they are more receptive to, and I'm certainly seeing, because I usually have those initial conversations with everyone, is that I've never seen so many inquiries come through before in terms of wanting to raise awareness with their staff in their workplaces, sporting clubs. We've had soccer clubs in New South Wales come to us as well. So there's certainly more of a drive around this conversation, and that's probably on the back of a lot of the work that the government's done in terms of having those promotional campaigns as well, and what's happening in our schools as well that you were linking back to around adolescent violence. Is there's a really big conversation around how we can play a role in that as well.
Great. And part of our terms of reference as well are about suicide or threats of suicide being used as a tool of coercive control. Is that something that you speak to organisations about? And if so, what do you tend to inform them about? And I suppose vice versa, is that something you hear from organisations that you're training or speak to?
So around coercive control, that certainly comes up in terms of mapping that and then looking at what that would, like the umbrella of coercive control, when we have those conversations, and then what that might mean around the suicide risk. So that is something that we do bring up, because it's something that the person who's using violence can threaten as well to a victim survivor. And then you also have that as well around the victim survivor as well.
And are there particular, I suppose, ways that you prepare organisations for dealing with that, or how to assess the risk when working with, I suppose, people who are using violence, who might be using suicide threats as a form of coercive control?
Yeah, so our trainers will go through that in the training. So for example, our coercive control training, that predominantly focus on that, but all of our training, we do have coercive control inbuilt into our FDV training. And so they will kind of look at, they look at the risk identificators. They'll look at maybe the 7 stages to homicide as well. Certainly we do that with the police. And then they'll kind of look at, they'll kind of map that out, and then they will have those conversations around the suicide risk. They might bring in a lot of organisations bring in de-identified cases, so that we can help support them around that. We're working with a regional Aboriginal community group at the moment who's actually asking for something that is related on suicide risk too. So that's something that we also provide supervision and consulting around, where we can support those organisations who don't understand or they don't know what to do, and we're providing that DV support to them in terms of the risk assessment and the safety planning, and then the advice around those cases.
Thank you. That's all the questions from me, Ms. Tanner.
Thank you.
Ms. Whitty.
I don't have any questions. Thank you.
Oh, lovely, thank you. Look, I do have another question. The education and training that you're providing, does that include helping people to understand how to recognise suicide risk? And I'm thinking particularly those, if you're delivering it to a corporate or a sports club or that sort of thing, like, are you actually talking to them about the risk of suicide and about recognising and what to do if they do feel somebody's at risk?
Yes, so our trainers do look at that, and they will help them with that in terms of referrals and support. But actually, in terms of where they can go at the moment. There isn't actually those referral pathways, which is something that we are recognising in terms of when we are doing training and we have referral pathways. It's looked at under the mental health as well. So not recognised as family and domestic violence in terms of what we're seeing in terms of training. But that's something certainly I can ask our trainers as well to provide some more information if you like.
That would be very helpful, thank you. Any other questions? No, lovely. Look, Ms Tanner, that's been really very helpful. Thank you so much. And thank you for the work that your organisation does across the country. It's really comforting to know that there is professional training that has that level of standards across the country. So thank you very much for that. I do have a formal little thing to say to you. Thank you for your attendance today. You'll be sent a copy of the transcript of your evidence to assist you with answering questions taken on notice today, and you'll have an opportunity to request corrections to transcription errors. Once you've received the transcript, you're asked to provide responses to any questions on notice within 2 weeks, and the additional information that you've suggested you'll be able to provide would be great as well.
Absolutely.
And so provide that to the Secretariat. The Secretariat will confirm these arrangements when distributing this transcript. Please note that all responses to questions on notice will be published on the committee's website as submissions to the inquiry. What else was I going to say? I was going to say something. Oh, if there's anything else that you feel that you do want to add, please do. We are running slightly behind with the transcript, so it may take maybe 2 to 4 weeks to come out to you. So please don't think we've forgotten you. And thank you so much for the work that you do.
And sorry if I couldn't answer everything, but we'll certainly get them back to you in written format. So thanks for the opportunity to be here today.
Thank you very much. Appreciate your time. Thank you.
Okay, bye.
Thank you. Great, because I can't read that far. All right, I think we have our next witness online. So I now welcome representatives of the West Australian Department of Communities to give evidence. For the Hansard record, would you please state your full name and the capacity in which you appear before the committee?
Thank you. My full name is Nicole Emma Leggett, and I'm participating today as the Acting Assistant Director General for the Department of Communities, responsible for our strategy, regulation and legal areas.
Lovely, thank you very much. Although you're not required to give evidence under oath, this hearing is a legal proceeding of the Parliament and it has the same standing as proceedings of the House. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege and is being broadcast. I'll do a quick whip around of who we are. So I'm Louise Miller-Frost. I'm the member for Boothby, which is in Adelaide's southern suburbs.
I'm Claire Clutterham, the member for Sturt, also in Adelaide in the east.
Mr Gregg.
Matthew Gregg, member for Deakin in Melbourne's east.
Ms Whitty.
Sarah Whitty, member for Melbourne.
Mr Ng.
Gabriel Ng, member for Menzies, also in Melbourne's east.
And our Deputy Chair, Mr Hawke, has just popped out, but he'll pop back in. Would you like to start with a brief opening statement before we proceed to discussion?
I don't have a formal opening statement, but I thought I might give you a bit of context about the Department of Communities and my role in it in terms of where we sit in the broader government landscape around strategic policy in the family violence and mental health areas.
Lovely, thank you very much.
So the Department of Communities is a human service agency in Western Australia, and we have responsibility for a range of functions, including our child protection and family support, disability services. We work across the homelessness areas, prevention of family and domestic violence. We take carriage of the implementation of the Royal Commission into institutional responses to child sexual abuse. We provide our state's emergency management responses, and then a range of responsibilities in a number of smaller ministerial portfolios that are broadly grouped around inclusion and participation. I guess what I wanted to draw your attention to is we are the agency that has carriage of coordinating strategic policy around family and domestic violence. And to do that, we have an Office for Prevention of Family and Domestic Violence, which exists in the division that I'm responsible for. So within that office, we do all of our strategic policy work, including Commonwealth Intergov. We do the service design and commissioning work, so our existing services as well as our new ones. We have responsibility for supporting integrated responses to family and domestic violence, and we also have a dedicated system reform team and a practice team. And the practice team's focused on the service delivery that we run within our own agency, particularly child protection and family support, and making sure that that's family violence informed. So, yeah, so lots of cross-cutting opportunities, but also that dedicated family violence focus.
Thank you. And your submission included the Ombudsman's inquiry into the investigation into family and domestic violence and suicide. Was that something that the Ombudsman self-directed, or was that something you commissioned?
No, so the Ombudsman self-directed, so they have carriage of our child death and family and domestic violence fatality review processes in Western Australia. And in undertaking those reviews, which are typically individual or case-by-case in nature, they at times can initiate what they call an own motion investigation, which might be more like a group or a system-level review. And in this case, they conducted an inquiry around the intersection of family and domestic violence and suicide. They've also done at least 2 investigations, to my knowledge, around suicide more specifically.
Thank you. Now, there were a number, I'm just trying to find my number of recommendations, but in terms of the recommendations that the Ombudsman put up, are there some that you think are particularly transferable to a national prevention strategy, or are they more that state-based?
I think that there's lots of transferable content in the findings and recommendations that they made, and I think they are supported in a lot of the Commonwealth state discussions, particularly in the family violence, family safety area that I'm part of. I think some of the things that the Ombudsman picked up on that we see replicated in state and state Commonwealth policy is the issues around integrated responses, issues around a continuum of service response that doesn't just attend to immediate crisis and safety issues, but also follows through to support recovery, healing and re-establishment. I think they talked quite well about the importance of broader workforce capability and uplifting adjacent sectors to be family violence and trauma informed, and then vice versa, uplifting specialist family and domestic violence services around being informed about particularly suicide prevention, but also about broader mental health issues. And I think they speak to issues around data collection quite well, understanding that that's a bit of a vexed issue from a national perspective.
Yes, it is indeed. So in Western Australia, do you do a standard death review for suicides or for suicides in the context of family violence?
So I'll tell you what I know, but I might have to come back to you with a more fulsome answer. So my understanding is that we have 2 separate oversight processes that variously look at suicide or family and domestic violence related deaths. So the Ombudsman looks at child death reviews and family and domestic violence death reviews. And in the context of that, they receive data about family and domestic violence suicides. They don't always undertake detailed inquiries or analysis about those suicides, but I understand that they receive that data and information and have the choice about whether they take their inquiries further. We also have a state coroner that has the opportunity to do inquiry work as well around certain deaths. And probably the most recent example that I can think of is that they undertook an inquiry into 16 suicides of young people in the Kimberley, looking at commonalities between those deaths of those young people.
So I'm just taking some notes. And you mentioned the issue of data collection being vexed, and that is certainly what we're finding across a number of jurisdictions. In terms of the data that the Ombudsman called upon, I'm assuming that they have fairly broad powers and can get them from government certainly, but also potentially not-for-profit and private providers as well. Is that a standard thing, or is in terms of the other death reviews that the coroner and the Ombudsman are doing, or is it specific for that particular piece of work?
Yeah, so the Parliamentary Commissioner legislation that the Ombudsman operates under has Royal Commission powers. I'd say, though, that they mostly operationalise those powers through their various functions in relation to public administration. So typically they're dealing with state government agencies as opposed to extending to non-government or Aboriginal community-controlled organisations, although they do often work with state government agencies around our contractual relationships in those spaces. So I don't know how they pull the data that's available to them on a systematic, regular basis. So my experience is more on the case-by-case basis, or when they're undertaking an investigation like they did in this case around family and domestic violence and suicide, which allows them to dip in and ask for information and to be provided by state government agencies. But I don't know that it's necessarily systematically or proactively done on a regular basis.
Okay, so do you know if there's a suicide death register that keeps track generally? Or?
Well, I was looking at the submissions that came forward from Western Australia, and I note that the Mental Health Commission has provided some more current data around the intersection of family and domestic violence and suicide. And I'm just checking where that was drawn from. So the reference that they've included there is the West Australian Suicide Monitoring System, which is facilitated through the Mental Health Commission, and the quarterly report on suicide statistics through the Coroner's Court of WA.
Okay, lovely. I'll go back and have a look at that one. Thank you. I'll just ask one more question, then I'll pass over to my colleagues. The Ombudsman's investigation found that children are often overlooked as victims in their own right, and that is certainly something we've heard from a number of jurisdictions. Do you have any sort of ideas about what changes we need to look at to ensure that children's experience of family domestic violence are centred for them as primary victims rather than observers or bystanders? Or
So I guess perhaps I'll talk a little bit about how we're approaching it in Western Australia, which is a bit of a kind of twofold piece. One is we are working on quality standards, practice standards that lift up children and young people in terms of being quite direct and explicit about what's expected in terms of services that are provided to children and young people through what we're already contracting. So refuges and safe houses, safe at home programs, outreach programs, hubs. We have a range of different outreach models. So we're working on lifting up practice in the services that we already have, but we're also working on commissioning and contracting dedicated services for children and young people. So I would say that up to about 3 years ago, when we had a family and domestic violence task force in Western Australia, we did already have a range of services that provided dedicated family and domestic violence counselling for children and young people, but they weren't commensurate with the magnitude of the problem in terms of how many people they could see year on year. So we've been investing in additional specialist services, investing in dedicated healing services for Aboriginal children and young people, through, I would say, models that blend therapeutic intervention with practical assistance and support, as well as embedding responses to children and young people in broader hub-type model arrangements where we have multiple different types of services co-located in one place to provide a more holistic response to the adult victim survivor and children and young people.
Lovely. Thank you very much.
Thanks, Chair. Thank you very much for being with us this morning. I just had a few questions about the recommendations themselves. Primarily, I'm interested in the progress of implementation and what the barriers to implementation are. But I'm also interested in your thoughts on just the nature of the recommendations. And I had two observations on them. Firstly, I found them in some cases to be very vague and broad and not real. I was like, oh, what does that really mean? There was one, I think it was number 6, that just said the Department of Community should note the investigations and come up with some strategies. I was like, yep, sure. What does that mean? That I didn't think that was very sort of instructive to the department. So that was the first observation. And the second one was, I think it was number 3 from memory, was talking about taking steps to record the number of young people affected by family violence in WA, which again seemed to me to be suggesting that the data that's available is I mean, not non-existent is not fair, but gosh, that's a very low point to be starting from, because unless you have that information, it's very hard to come up with targeted policy responses and directing resources, etc. So I just wondered what you thought of the recommendations, and then what's happening in terms of implementation, what's stopping implementation, what are the successes been, etc. Thank you.
Yeah. Thank you for the question. I probably won't make too much comment about what we think about the recommendations, but perhaps I'll focus a bit of time on what we're doing and what we're still doing to support their implementation. So I think, as you might be aware, the arrangement in Western Australia in terms of how we interact with our state ombudsman is that when they conduct either an individual case review or an investigation at a system or macro level, after recommendations are made, usually 12 months, but sometimes shorter, sometimes longer, they provide a follow-up report to track progress of implementation. So that report is available online, and I believe it was published in 2022, which gave sort of a 12-month mark around implementation. Okay, what I will say, though, is that in 2023, we, for a range of reasons, a family and domestic violence task force was convened in Western Australia. And actually those reasons were, we had 2 family violence fatalities in 2 weeks and a significant outcry from our specialist services sector about a lack of attention and a lack of investment in the specialist family and domestic violence area. So the task force was convened for a period of 6 months. It involved directors general from across a range of government agencies, as well as representatives from community sector and Aboriginal community-controlled services. It was chaired by the Director General of our Premier and Cabinet agency, as well as with a senior Aboriginal woman was the other co-chair. So that task force concluded with releasing a system reform plan, so a 5-year plan, essentially about how we do better in our responses to family and domestic violence, both in the specialist services sector, but perhaps more pertinently, across government in the way that we support all adjacent services, systems and areas to provide that specialised response. So Mental Health Commission, along with police, with justice, with education, with health, were at the table for the task force, and they're enduring partners in the implementation around system reform. So it came up with 17 actions that exist across 4 areas, being risk assessment, risk management, information sharing, and workforce development. And really the focus of those 4 things is about how we improve outcomes for victim survivors by taking a more collective and holistic view of the whole system and all of the various touch points that particularly victim survivors might have in all of those service settings, and really understanding that if we only focus on specialist family and domestic violence services as being the response to family violence, we're never going to have enough capacity to provide the level of response that we need, because the quantum of demand is so high and people aren't always presenting in that specialist space. Very often they're presenting to their GP first, or to the police first, or potentially straight to the courts or to a mental health service. So we really wanted to have a focus on uplifting all of those adjacent sectors so that they were best equipped to identify family and domestic violence when it was presenting and understand and operationalise their role in being part of a response that's safety focused, but also trauma informed and assisting in that broader recovery and re-establishment process. So we report on our implementation 6 monthly, and we are progressing all 17 actions. And the reason I'm talking about this is because a key part of developing that system reform plan and taking forward the actions started with going back to some of our ombudsman reports like this one and understanding what are the critical issues that we perhaps haven't sufficiently addressed or haven't addressed in a way that's created real structural or system change about how we can really create different outcomes over a long period of time. And I think what we'd experienced in Western Australia in this area is whether it be through oversight agencies or strategic policy changes that were brought into effect, but they create change for a small amount of time, but then other priorities overtake. So what we've been really trying to focus on in terms of our system reform is how we create changes in a way where they can't be undone. So we're introducing a new common risk assessment framework in Western Australia, which is the same that many states and territories are also doing. And it includes a focus not only on perpetrator patterns of behaviour, coercive control, and the immediate safety risks, but also the wellbeing vulnerabilities for victim survivors and the ways that we need to provide more holistic support. We're working towards a central information point that will integrate government data as a starting point, so it will collate risk-relevant information so it's more readily accessible. And we've looked to Victoria around that as being an example of something that we want to bring to Western Australia. We are focused on workforce development, so we released a capability framework which sits across our whole service sector, including mental health, and talks about what are the capabilities that we expect and require. And to support implementation of that, we funded a dedicated workforce development organisation focused on family violence, and their responsibilities are to support training and workforce development in our specialist services, but also across government. And they've got a bit of a two-speed role in that space, I guess, in terms of they'll do that hands-on training and support for our specialist sector, but for government agencies, they'll provide more like a quality assurance role and making sure that the things that they're making available to their staff are meeting the capabilities, are family violence informed. We are in the risk management area, working a lot on integrated service delivery. So we've standing up one-stop hubs in Western Australia, as many organisations are, many states and territories are, and those hubs start with a design process in the community that they're going to be established in, and many of those design processes have identified that the importance of co-locating family violence and mental health services, as well as services for children and young people. We have therapeutic refuges in Western Australia where the service model is a combination of family and domestic violence, alcohol and other drug and mental health support in the same service model. And we have family violence services delivered by Aboriginal medical services to try and provide more holistic service responses, particularly in regional WA. And we have family and domestic violence response teams, which the Ombudsman report speaks to. So it's a partnership between communities, child protection workers, WA Police, non-government family violence advocates and the Department of Justice Community Corrections. And essentially their job is to receive all of the police reports that are about family violence, work out what we already know about this family, what the early assessment of risk is, and whether a response is required and who's going to facilitate that response or whether it needs to be joined up. So we have had response teams for a while. The key difference is we are moving towards 7-day-a-week service delivery. So what was a 5 Monday to Friday response is now in regional WA operating 7 days, and we're rolling out Metro to 7 days as well. And we've also added a function for multi-agency case management of high risk, high harm cases. So the people that we're most worried about, the people that are most vulnerable. So we've got dedicated resources for bringing that much broader multidisciplinary response together. So I guess we're working on integrated service delivery on multiple fronts and always looking for what else we can do, but trying to do it in a way that it can't be easily undone. And I think that that's really important.
Yeah, that was a really great overview of and it's heartening to hear that progress is being made in relation to the 17 recommendations. There's a lot more going on, a lot more investment, a lot more government community will than the recommendations in the Ombudsman's 2022 report suggest, which is a positive thing. And in terms of common challenges you run into when you're, looking at implementation of recommendations, there's people that work in this space. There's always goodwill, right? Everyone wants to do what they can to reduce the impact of domestic family violence. But what barriers do you typically run up against? Is it resourcing? Is it funding? Is it policy? What's standing in the way?
I think so we've certainly got a lot of goodwill, and the government has invested continuously and significantly. So since 2017, I think we've had just over 800 million in new initiatives invested in WA, but we were growing a pretty low base. So our 2017 funding through my agency for specialist family and domestic violence services was about 40 million. Now we are at about 177 million. So that growth is definitely there. And we've got a forward program of further growth, like sort of bringing new services online. I think some of the challenges that we've faced are similar to what Victoria did in the wake of their Royal Commission, where it's not always a money problem or a funding problem. So because we've been rolling out services relatively quickly, we've found it difficult to find a workforce that can staff those new services, and that leads to an intensity of support that needs to be provided on the job, which can be difficult for small organisations to manage. Regionally, we have a range of additional challenges around housing availability, which I think are quite well documented for WA. I would say we've also got an issue just in terms of the expanse of the state around how we provide equity in availability of services. So we've really had quite a significant focus on making sure that we've got a range of different service types and service responses in regional WA, but largely what that means and looks like is that we've got it in regional towns and sometimes in smaller towns, but a lot of our remote communities wouldn't have access to the same types of supports and services.
Yeah.
And then I just think a more global issue is about sustaining momentum, and there's always new priorities, there's always new things that come up. So I think we've spent quite a bit of time in WA about trying to stand up governance arrangements that help us kind of keep our eye on the ball around continually generating that momentum around delivery.
Yep. Thank you. Thanks very much.
Thanks,
Chair.
Ms Whitty.
Thank you, Chair, thank you. I just wanted to, you talked a lot about multiple services in the one place and integrated services. And then I'm just wondering whether you have a viewpoint on whether it seems to be that services sort of become all in one and then they spread out again and become specialists and back in and out all the time, and whether you had a viewpoint on which model works best.
Yeah, it's a great question. I think my sense about what works best is when integration is formalised in such a way that it isn't based on relationships. And I think we see a lot of goodwill generate a lot of place-based partnerships between organisations and services that are based on a point-in-time relationship between senior people, but because they're relationship driven, they might not last when those senior people move on. So I guess probably where I feel like it works best is where things are really purposefully designed for integration and they're commissioned with that in mind, and it becomes part of the contractual requirements beyond the relationships that might exist between the various parties that are involved.
And then further to that question, we often talk about, and you've mentioned it as well, that children should be considered as victims in their own right. And does that then, in terms of the services, then lean into specialist children's services separate from the adult services, or are we then again considering them together?
I guess my view is ideally you'd have a bit of both, because I think, like if I just think about one example, if I think about supported accommodation of refuges and safe houses, the majority of children that are coming into those services are typically quite young. So the highest cohort of children in a refuge is under the age of 4. So the logic of having a standalone service for a child under the age of 4 might not quite be there. Like, it makes more sense potentially for some of that service to the child to be in context of the mother within the refuge and safe house. But then certainly when we're at the other end of the spectrum and we're talking about young people who may or may not have an enduring relationship with the adult victim survivor or other members of their family, it makes a lot more sense for them to be able to access those services independently and untied to whatever service might be providing to the adult in their life. So ideally, I see a bit of both is important and relevant.
Thank you. That'll do. Thanks, Chair.
Thank you. Mr. Gregg?
Thank you, Chair. I note that WA is kind of in a unique position in relation to its family court. It has a state-based court, whereas the rest of us are in a federal system. Has that provided any advantages in terms of integrating the family law court system with the child protection system and other family services?
I definitely think it has advantages. It's still not a foolproof system, and I think we experience in WA some of the same challenges that are experienced in other places. But what it does do is that we have opportunity around localising information sharing arrangements and localising service delivery arrangements. So as an example, our agency has a placed officer at the family court, and their principal role is to support that information sharing and, when it's necessary, case coordination on children and families that are common between both settings, so family court and child protection. So I think those types of things are really useful in WA. Our family law framework is very similar to the national law, though. So some of the similar challenges that are documented and reported on nationally would exist in WA. Although I believe that we have, I know that we have more like a case conferencing model, and much like other states and territories, it tends to be the most contentious and unsafe cases that end up in court. A lot of other matters are dealt with through mediation or family dispute resolution. So we've got processes in place, for example, for independent children's lawyers, for court counsellors who essentially work with either party to understand what's happening and then to be part of a process of making recommendations to the court about what should happen in terms of parenting orders. So, yeah, I think there's definitely some benefits, but still some of the similar challenges.
So without trying to open up a whole new can of worms to this inquiry, do you think there's room for improvement in the way that we utilise family court as an opportunity for supportive intervention?
I'll just talk about, the short answer is yes. And I think, something that we've thought about over a number of years and has been documented nationally is this kind of complex issue where families are sitting between 3 separate legal processes. So family court, care and protection, which might be children's court from a child protection perspective, and then like a third process either being civil or criminal law, whether it be restraining order or criminal law related. So I don't know that we've really solved that for victim survivors in WA. We would still require them to appear in all three courts to deal with the respective matters. I think opportunities around a single court for kind of like whole of family approach could be useful, but practically I don't know how we would facilitate that.
I think that it'll have to be its own piece of work. But I'll ask one more question about it. Given the documented kind of prevalence of family and domestic violence, is it fair to say it's probable that there's a lot of cases that are going to mediation where we know for a fact there's a power imbalance that would make mediation inappropriate? Or family dispute resolution?
I think it is publicly documented that there's a number of family and domestic violence cases in mediation and in family dispute resolution. Maybe what I would say is that in some of those providers in Western Australia, the organisation providing those services also provides some of our specialist family and domestic violence services. So there's some opportunities about the ways that they join up the supports and services that sit around that family. But certainly risks sit in that space if it's not managed appropriately.
Actually, I did have one more question around in terms of designing, the work you're doing at the moment. I guess two questions. I'll ask them in one, then pass it on. Firstly, who is ultimately accountable for this work? And secondly, have you got a clear outcomes framework that you're working towards against which success and failure can be measured?
Great. So I would say that in Western Australia, we have a Minister for the Prevention of Family and Domestic Violence. So my primary relationship is with that office in terms of accountability and reporting, and she's the one that releases our 6-monthly reports on implementation progress. But we're also very clear that actually it's a bigger issue than what might be managed out of that portfolio. So, for example, the Minister for Police, the Attorney General, the Minister for Health, they're all very much involved in the implementation and delivery, because some of the things that need to happen need to be managed through their line agencies and their portfolios. We do have government has committed to an evaluation of our system reform effort. So we're in the process of the process evaluation at this point, which will talk to us about how we're tracking with our implementation activities, but there's also an outcomes evaluation that will follow. So yes, we have documented and are working towards outcomes. What I would say about that, though, is it's a very difficult area, just in the sense that safety is very rarely black and white. There's a lot of grey that goes in between, and there's a lot of reasons why a change over here hasn't translated into a change down the other end of the spectrum. So we've tried to take a relatively comprehensive and nuanced approach to how we understand the impact of the work that we are doing. I'm just not, it will remain to be seen whether we can really demonstrate quantum of impact at a macro level. I think that's the point. At the macro level is sometimes harder than at a case level.
I guess it's also about informing design of what interventions you choose over others and where do you put your finite resources. All right, well, thank you very much.
Thanks.
Mr. Ng.
Thank you, Chair, and thanks, Ms Leggett, for making the time to speak with us today. I was wondering if you could expand a bit on something that you mentioned to Ms Whitty about the contractual arrangement for service providers and how that's worked. Does it mean that you have an umbrella organisation? Does it mean that there's a requirement in the contracts to work with other organisations? Would you be able to say what's been an effective model?
Yeah, so I'd say that our one-stop hubs are quite an effective model from a contracting as well as an operational perspective, and they operate with a lead or a backbone organisation that then has partnership arrangements with its consortia members. So we enter into a contract with the lead, and within that contract it specifies the consortia, the various arrangements around who else is involved, to what quantum or capacity, what they'll deliver, what the global outcomes are, and what their more individual kind of activities and outcomes are for each partner. And that then provides us with a single contracting point, which is useful because we have a single point of accountability, but that organisation has clear governance and frameworks in place for managing its relationships with each other. So that's one way that we've done it. In our response teams, which is a non-government partnership with government, our contractual relationship with the non-government organisations that sit with us in that space is more individual, but then we have global governance arrangements with police, with child protection, with justice and the non-government sector around how that response operates, both in terms of a reform and change perspective, but also just day-to-day operations. And that can be, I mean, overall, it runs really well. We've got a statewide integrated response, but it can be more impacted by changes in approach or decision by individual government agencies, I would say. So that governance more broadly becomes really important in terms of holding it all together, but also those accountability to relevant ministers becomes really important as well, that they understand that they're bought in, that they're kind of reinforcing the importance of that response.
It sounds like a huge body of work to coordinate things and also make sure that it remains a priority.
Yeah, lots of talking.
I'm sure. And just in terms of, I suppose, the reporting aspect of things, so in a lot of ways, we want to make sure that we're gathering data on the relationship between domestic, family and sexual violence and suicide, and also what might be effective in reducing the risk of both. But also very conscious that a lot of frontline services, whether they're government services or non-government organisations, are already pretty stretched and not wanting to increase the administrative burden on them. I'm just wondering if you have any reflections on your experiences with trying to get that balance right between getting the right data, and especially data that might be useful to organisations themselves, and not increasing the administrative burden.
Yeah, so I think it's a great question, and within WA we've got processes in place for linked data from government. So we're working on a data sharing solution for risk assessment, which I spoke about earlier, a bit called the Central Information Point. But then beyond that, we've got processes for linked data, so we can understand how people track and move through the system, which gives us insights at a more macro level about what's happened, what those opportunities for intervention are, and outcomes more at a kind of cohort or population level. What makes that really challenging in terms of extending that into specialist family and domestic violence services is how many different databases are used amongst the various people that we contract with. And I've got no doubt that this has been raised by other people. But as an example, many of our supported accommodation services and our Safe at Home programs, they feed into the National Specialist Homelessness Services Information Platform, which is managed by the Australian Institute of Health and Welfare. And so within that database, we're doing some work around how we can enable some functionality around understanding that the Jane Smith in this refuge over here was the same Jane Smith that was in that refuge over there 2 years ago, or vice versa. So at the moment, we don't know that. We can't look at that, but we're trying to make some changes to that database so that we can. But then how we can extend that type of functionality in a safe way to other specialist family violence services, so we can have a clearer view about where people are, where they've gone to next, reduce the burden on them to have to continually repeat their story, because that information will move with them through the service system. But it is a challenge. It is a piece of work, actually, that I believe the Department of Social Service is leading around I'm going to get the name wrong, but it's essentially a piece of work around a common database for specialist family and domestic violence services. But it's been a long time in development, and I'm not sure exactly where it's up to.
Is that the data exchange that you might be thinking of?
I think so. Yeah.
Thank you. A huge challenge with trying to get some of the relationships between the huge range of databases that there are. But my last question is around, I suppose, how you're sharing information with other states. So, clearly, you've had reference to the Victorian Royal Commission, there's the South Australian Royal Commission, and what other states and territories, what innovations they might have. What's the model at the moment for how you're sharing that information? And I suppose also, what role do you see the federal government as being able to provide that we might be able to better disseminate information from this inquiry or from other inquiries that might be?
So for as long as I can remember, we've had a Women and Women's Safety Ministerial Council, which currently is led by Katie Gallagher and Tanya Plibersek, with all state and territory women and women's safety ministers. A couple of years ago, when National Cabinet focused on gender-based violence as one of their priority areas, that led to a significant additional body of work that's in addition to what women and women's safety ministers were already working on under the national plan. So now women and women's safety ministers have a program of work that they're responsible for delivering, as well as a coordinating function in relation to attorneys general, information services ministers, and another group, which I'm forgetting. So I think at that highest level, we have a good mechanism for information sharing nationally. What that looks like in terms of how it cascades down is various different governance groups and working groups between states and territories. I would say that it's very collegiate. We're very open to sharing information. We have people come and visit from other states and territories, and we send our people out to visit particular types of service responses or whatever it might be. So I'd say the information flow and sharing is good. For the purposes of this inquiry, though, potentially there is opportunity about kind of bridging that divide with the more traditional mental health sector. And I think, the areas where, I guess just scanning the submissions that WA stakeholders put forward, although mental health are part of our governance for family violence system reform and part of our stakeholder group that we're working with around our system reform agenda, I think there's a lot that could be done, a lot more that could be done to help bridge that divide between those sectors and the ways that victim survivors in particular navigate them and are supported potentially through multidisciplinary responses. And I'm assuming that that's something that people have spoken to you a lot about. I think philosophically they're coming from very different starting points, one being more clinically focused and potentially more individualised in its response, another being more kind of family systems, social service response. And I think that, our Centre for Women's Safety and Wellbeing put it quite well in their submission. In many ways, effective specialist family and domestic violence services are suicide prevention, but it's really about recognising that sort of cumulative and compounding trauma that people experience and the extent to which that then starts presenting as clinical distress or something that might start to resemble a mental health issue, and what that transition into that service system looks like when actually the genesis of the issue is violence, is safety, is cumulative and compound trauma, and not something that can just be dealt with or managed through a one-to-one relationship with a clinician. So I think, to the extent that there's opportunity to really dive into that and unpack that would go a long way. And I think although we're talking about suicide and suicide prevention, we see it on the very other end of the spectrum as well, around quite acute psychiatric issues where that person, in a very small minority of cases, actually creates a risk to the safety of their family members. And we've had a number of cases in Western Australia where that's had very awful outcomes. So I think it's an important piece of work to have focus on, and beyond the suicide prevention focus, there's a relevance to looking at mental health and specialist family and domestic violence services and how they go together more broadly, including for a response to someone who's identified as a perpetrator of violence.
Absolutely, and that's definitely something that we've heard. Those are all the questions from me.
Great.
Thank you, Chair and Ms. Leggett.
Thank you very much. Mr Hawke.
Yeah, I think I'll just ask a kind of a final follow-up question. Mr Ning there had an excellent series of questions along the lines I was going to ask about the, your interaction with the Commonwealth and those things, and I heard your evidence. Thank you for all of that. I guess my question is about the similar topics to Mr Ng about this. So you've given evidence there about the Ministerial Council, which is going well because it's a priority of National Cabinet, which makes sense. But given the work that WA has done, the Ombudsman, with the report, I mean, it's an excellent report. It's something everyone, from every jurisdiction could basically pick up. It's got 9, it's got some well thought out, well laid out recommendations in a very simple format, which isn't always the case. These things can be very big and complex. I don't know, look, I'm looking at you on a webinar, but you're probably not old enough. But you might be very young, you might predate COAG, right? So do you remember the Council of Australian Governments before COVID? Were you around in that era?
Yes.
Yeah, great. Okay, good. Excellent.
I was, absolutely.
Yeah, you're young enough to remember. Great. So the thing about that I have is now we've got rid of COAG out of it as a result of COVID, and we have National Cabinet. Let's say I accept it's a national priority of National Cabinet and it's a good thing. But let's say it wasn't, because plenty of things can't be priorities, like let's say it wasn't able to be. I mean, isn't there a need for another mechanism for constant, coordination of work between states, based on something like your Ombudsman report? An Ombudsman report in your state goes to your government, sure. Some people might say that's just for your government, which it is, but actually, those recommendations, as you say, people come and study, they learn. But don't we actually need a kind of a permanent coordinating body that says these things can just be lifted and implemented in other states and jurisdictions? I mean, would you have any comments about that?
Yeah, I'd say my first thoughts are that I totally agree that there's, as much as we have really strong and solid working relationships with other states and territories and with the Commonwealth, at the end of the day, our government's priority and agenda is what takes precedence. And while we're looking up and looking around to think about what we can learn and how we can integrate that into what we're already doing, we pursue what we've been authorised to do kind of with a one-track mind, if I can put it that way. So I wouldn't, for example, look at an inquiry that's been done in Queensland necessarily and think, I really need to implement that in WA. So I do think that there is a opportunity for a dedicated forum or something where there's the ability to consider what of state-based inquiries might actually or would warrant being elevated for national implementation. And it may be that Women and Women's Safety Council or National Cabinet are the appropriate forum for that, or potentially through the Domestic and Family Sexual Violence Commissioner, which is a relatively new role in that sort of broader kind of governance landscape for family and domestic violence response. They provide a really effective role in coordinating and supporting sharing of information, and they provide that yearly report to Parliament on how they see things tracking. But again, it gets to be very focused on specialist family and domestic violence response, which does extend to other agencies, particularly police, courts, child protection, housing and the like. I guess it's about that nexus, and do we have enough sitting at that nexus between mental health and family and domestic violence? And I'd say at the moment that is an area where we could have stronger relationships, both nationally and between states and territories.
No, thank you. I think we hear that. Certainly, I'm sure on my behalf, but I'm sure the committees as well. I'd love to pass on our thanks to the Ombudsman. I mean, this report is probably one of the most relevant pieces of work that we've seen in our evidence so far. Fantastic to have it available to us. But yeah, that'll be. I could ask you a lot of questions about how that would work, but I think that evidence, I'll take that, Chair, in relation to that, and we will think about that further.
Terrific. Thank you very much. Look, thank you so much for your attendance today. That has been really helpful, and thank you for your openness in responding to the questions. You'll be sent a copy of the transcript of your evidence to assist you in answering questions taken on notice today. And I think you might have offered a couple of extra bits of information. That would be great. And you'll have the opportunity to request any corrections to transcription errors. Once you've received the transcript, you're asked to provide responses to questions on notice within 2 weeks. Transcripts are taking a little while to come out at the moment, so it will arrive. Please forward these and any additional information that has been requested to the Secretariat. The Secretariat will confirm these arrangements when distributing the transcript. Please note the responses to questions on notice will be published on the committee's website as submissions to the inquiry. For those in person or listening online, if you've heard anything today that's upset you or caused distress, please reach out to 1800 RESPECT, Lifeline, 13 Yarn, Kids Helpline or any other support services. There's also a Parliamentary Workplace Support Service and Employee Assistance Program for Broadcasting, Hansard, the Committee Secretariat and the Committee itself. I now declare the public hearing closed and the committee adjourned until 4:30 on Tuesday the 11th of August 2026. And thank you everyone for your participation. Thank you.
Thanks, Chair.